morning, everyone. I welcome all pathologists around the world for our 88th IAPM Kerala chapter meet. As we all know, this current scientific era, there are various changes taking part in various fields. So as in pathology, right from the molecular, that is right from the histopathology to the molecular genetics. So this is the right time to have a conference on neuropathology. So here we start, and this corona is still on air. We are just keeping on with our fourth consecutive virtual IAPM presentation. So going on for the official inauguration, I welcome the Secretary of IAPM Kerala chapter, Dr. Annie Previn, for the welcome address. Over to you, Annie.
Thank you, Dr. Siddhis. Good morning, my teachers, seniors, colleagues, and dear postgraduate. On behalf of IAPM Kerala, in association with Mindray, I welcome you all for the much-awaited 88th IAPM Kerala chapter meeting. First and foremost, I would like to welcome our guest speaker, Dr. Dilip Panikar, Senior Consultant Neurosurgeon, Aster Medicity, Kochi, who is going to enlighten us upon a neurosurgeon's perspective on neuropathology. And I extend my warm welcome to the moderator for the session, Dr. Neelima Radhakrishnan, Associate Professor, Regional Cancer Center, Thiruvananthapuram. The slide seminar session, the showstopper of our chapter meeting, is being moderated by two eminent neuropathologists. A warm welcome to Dr. Bindu M.R., Professor, Department of Pathology, AIMS Kochi, and Dr. Aparna Kovindan, Associate Professor, Government Medical College, Kozhikode. And let me also welcome our moderator for the free paper session, Dr. Nandakumarji, Professor, Government Medical College, Thiruvananthapuram. The support furnished by Team Mindray India need a special mention. And I wholeheartedly welcome all the participants for the various sessions and best wishes to each and every one of you. Lastly, the chapter invites all its members, consultant pathologists, and postgraduate across the country to be part of this event. Thank you. Now I welcome
our President of IAPM Kerala chapter, Dr. Rajan sir, for the presidential address. Over to you, sir.
Respected guest speaker, Dr. Dilip Panikar, chapter members, consultant pathologists across country, and my dear postgraduates. It's a warm good morning to all. Today it is our 88th chapter meeting and the fourth consecutive online meeting also. So last 2 years I was like an online president. So hopefully maybe the next time, that is the 89th chapter meeting, we can conduct it offline, because everybody wants to interact physically. And yesterday the postgraduate final quiz competition was over. Government Medical College Trivandrum won. Congratulations to all the finalists and the winner. So I think directly there were some 90, 95, near about 100 participants in the Zoom, and near about 400, more than 400 viewed its online through Facebook and YouTube. And I express my sincere thanks to the quiz masters, that is faculty from Government Medical College Trivandrum, as well as faculty from Regional Cancer Center. And as we know, our synoptic reporting format is midway. So we face some 12 modules were all completed, and some another 16 is pending. So we face some difficulty because we get only one bidder, and the cost raised by them was quite little high. So now we go for other firms so that we can see that the cost is the real one or it is above budget limit. So next week onwards, we will pursue with the rest of the synoptic reporting format. And another thing is that the number of pathologists in Kerala is sharply increasing. So far we have around 600, 650 pathologists in Kerala, consultant pathologists in Kerala, and more than around 200 students, the postgraduate students are there, including the first year to the final year. So the number of this pathology community is sharply increasing. So it's difficult to find a job for many of the youngsters as they desire. So that is another important problem that we are now facing. And many of the labs, again, you see that there is not a standardized, you see that charges for the biopsies as well as the cytology specimens. So many are underrated. They are cutting their charges, and again they are offering the report with a very low charge. So that is another problem that we are facing, and we have to get into all these things and make it a standardized format so that our younger pathologists will benefit from that. Moreover, you see, you see that we are planning to conduct an interactive platform for the younger postgraduates. Again, you see that the middle level faculty as well as that is the assistant professor to associate professor faculty are not getting enough space to teach. Maybe in their institution they get enough time as well as the place, but you see that whenever come to a meeting, they are not getting the enough representation. So the IAPM is actually taking over that responsibility. We are providing some platform for the middle level faculty to teach the postgraduates. So we are actually buying a Zoom platform very soon, and you see that every fortnightly there will be one teaching session for this particular faculty, and the audience that is meant is always the postgraduates as well as the younger consultants. So I am not standing in between you, and again coming to the topic today, it's the neuropathology. We have conducted a successful neuropathology webinar 2-3 weeks back. The faculty, the best ever in India, that is the NIMHANS faculty. And again, the moderators we know is Bindu and Dr. Abarna. And I'm not standing in between you and the academic session. So I think it is the time for the guest lecture, and Dr. Dilip Panikkar is actually again waiting for that. And so I am, it's wishing a very fruitful academic session this day, and thank you all.
Thank you, sir. Now moving on to our first scientific program, a neurosurgeon's perspective on neuropathology, clinical implication. Guest lecture is by the most popular neurosurgeon and apt person for this chapter meet to share his perception on neuropathology. Now I invite Dr. Neelima Radhakrishnan, Associate Professor, Regional Cancer Center, Trivandrum, to introduce our guest speaker and to moderate the session. Madam has done MBBS and MD Pathology from Trivandrum Medical College, worked as Assistant Professor ad hoc in Neuropathology from Sri Chitra Thirunal Institute of Science, Medical Science and Technology for 4 years. Now currently she's working in RCC for the past 6 years. So over to you, ma'am.
Thank you, Rajan sir and IAPM team. Good morning, respected teachers, dear friends and dear students. The guest lecture for today's IAPM conference you already know, and speaker is none other than Professor Dilip Panikkar sir. This topic is of great relevance to us, as we all know that there are many gray areas in the reporting of neuropathology, one example being stereotactic biopsies. I'm sure that Sir's lecture will throw light on all these issues. Sir is one of the most eminent and dedicated neuro-oncosurgeons in India. Currently, Sir is working as a senior consultant neurosurgeon in Astra Medicity, Kochi. He had done his MCH neurosurgery from Sri Chitra Institute and worked as additional professor there. He was a professor and HOD neurosurgery in Amrita Institute, Kochi. An eminent speaker, a great teacher with a depth of experience of more than 30 years in the field of neurosurgery, with a handful of publications in both national as well as international journals to his credit. On behalf of IAPM, without further ado, please do join me in welcoming Professor Dilip Panikkar, sir. Over to you, sir.
Thank you, Dr. Nilima, and thank you, Dr. Rajan, for inviting me to deliver this address. Let me share my screen, and then we can go on. Okay, can you see my screen?
Yes, sir.
Okay, thank you. Now, let me say one thing at the outset. The relationship between the neurosurgeon and the neuropathologist is something entirely different. They are very, very closely bound to each other. And the neurosurgeon depends to a great extent on the neuropathologist to help them make decisions and to plan management and to prognosticate. I am fortunate to have learned neuropathology from one of the most eminent neuropathologists in the country, Dr. V.V. Radhakrishnan, who was, even in those days, a very complete neuropathologist with an incredible depth of knowledge. And he personified what a neuropathologist, a complete neuropathologist should be. I have since then had the good fortune to work with some very, very talented people. A few of the names include our own Dr. Bindu, who's currently the neuropathologist at Amrita, Dr. Nanda, who was with us both at Amrita and at Aster, and many, many others. What makes neuropathology so interesting? The pathologies, the tumors and other pathologies that can arise from any of the intracranial structures are very, very diverse. And some of these, the neural tissues and some of the other tissues are not present anywhere else in the human body. They have their own unique identity, the pathologies that they give rise to, and it needs a very dedicated person who has a very broad vision to understand this entire gamut, this range of pathologies that we encounter. Let me take you back to the origins of neuropathology. In the late 1800s, stalwarts like Rudolf Virchow and Anthony Golgi had described cells and had spoken about and had described the origin of tumors from cells. But at that time, in the late 1800s and early 1900s, all intracranial tumors were called gliomas. And there was very little understanding of what these tumors were and how they behaved. Dr. Harvey Cushing, who is considered to be the father of neurosurgery, had this immense collection of tumors that he had operated. And not only had he operated them, he had meticulously documented by hand the findings, the clinical profile, the findings, and the outcomes of all these patients. And what they found at that time was there was no correlation between, there was very little to correlate between the kind of tumors that they saw and the outcomes. So Percival Bailey was a young person who wrote to Harvey Cushing asking for a position with him. And he joined him as a young trainee who went on to become a neurosurgeon a very successful neurosurgeon in his own right. But during the course of his work with Harvey Cushing, he worked on the collection of intracranial tumors, of glial tumors that Harvey Cushing had accumulated over years. And this was the seminal publication that was first presented in 1925 and published in 1926, which was the first ever classification of glial tumors, which not only described the tumors themselves, but also correlated these tumors with the outcomes, which was probably the first of its kind. And this was a classification that Bailey and Cushing had given way back in 1926.
Sir, your slide is not moving.
Okay, let me stop share and reshare this thing. Where are we? Okay, let me share this again. These sometimes do misbehave. Yeah, can you see my screen now?
Yes, yes, sir.
Okay, so, okay, I hope it behaves this time around. The classification, this was a classification of gliomas that was given by Bailey and Cushing way back in 1926. And you can see that many of the terms, many of the designations that they have given to these tumors are very much in use even today. They subsequently went on to other seminal publications, including schwannomas of a detailed description on medulloblastomas and detailed description on vascular tumors and hemangioblastomas. All these were in the late 20s. This was the next major contribution, where Dr. Cushing was joined by Dr. Louis Eisenhardt.
I'm sorry, sir, but it's not moving again.
Okay, there's something. Okay, is this visible now? Can you see?
Yes, sir, we can see that. We can see this.
Louis Eisenhardt?
Meningioma, sir.
Yeah, the meningiomas. Okay.
Yes, sir.
Can I just continue like this? I think the slide share seems to be a little bit of an issue.
No,
I
sir,
mean,
this is fine.
Yeah, now it's okay. Let's see if
Can
you
you
have
just
any other.
shift to next slide? Then we can just see.
Yeah.
Oh, yeah, it's going. It's moving, sir.
It's changing?
Yes, it's changing now.
Yeah, okay, great. Let's see, I hope it behaves. So this was a next major seminal contribution where Cushing was joined by Louis Eisenhardt, who initially joined Cushing as his secretary to help him with his documentation, went on to join medical school and complete her training in pathology, and then joined Cushing as a first neuropathologist. And between them, they authored this book on meningiomas, which contains descriptions of meningiomas and the pathology, many of which are relevant even today. On the right side, you see an extract, a page from the book that shows the hand drawing made by Cushing about the bony changes that are seen in meningiomas. And many of these are still relevant today in this day and age. They also established what could be called as a first tumor registry, where 2,000 brain tumor specimens were archived and a detailed documentation maintained, and this was a nucleus for the first tumor registry. Cushing maintained this tumor registry until he passed away until 1937. He passed away the next year. And subsequently, Louis Eisenhardt took over and ran the tumor registry at Yale till she retired in 1967. And this collection is still there in the Yale Museum, in the Yale Library Museum, which is remarkable for that. From these beginnings, we have witnessed a very dramatic evolution over the years with different techniques being introduced, newer understanding. From the early eras of pure microscopy and hematoxylin and using stains, supplemented by a variety of other staining techniques, to the introduction of immunohistochemical stains to understand protein expression, and then going on to genetics and molecular diagnostics. And this laid the basis for the standardization of pathological entities, which was given by the WHO in their blue books. The first one, starting from 1979, the fourth edition in 2007. With each edition, there were additions, there were modifications, there were newer techniques that were introduced. The 2007, the fourth edition was revised in 2016, where the first time the concept of an integrated diagnosis was introduced, which included molecular and genetic data. And this has led to the current iteration, the fifth version of the WHO classification, with its extensive, which extensively relies on molecular and genetic information to supplement the morphological and immunohistochemical information to arrive at an integrated diagnosis. The complete neuropathologist, in addition to being very, very well versed in neuropathology, must also be a clinician and a radiologist, be able to understand the clinical profile of the patient, the history, the progression, the clinical findings, prior treatment, the radiology, and the operative findings, all of which have a bearing on an understanding of the processes involved. It is very important to be in constant touch with the clinician and to consider the clinician's impression, both the clinical and the operative impressions that the clinician might have, that will help point the pathologist in certain directions. And as ever, all these are extensively discussed at multidisciplinary tumor board meetings, where not only is the diagnosis and the findings and the diagnosis are discussed, but even the management is decided upon. Let me take you through a few slides about to increase your understanding of some of the background of what I have told you, the clinical profile, and what we do as clinicians, the investigation, the treatment, and the management processes that have a bearing on the tissue that you receive for analysis. Brain tumors, as we know, can present in a wide variety of conditions, in a wide variety of clinical profiles, starting from raised intracranial pressure, seizures, a wide variety of neurological deficits, cognitive decline, endocrine disturbances. There can be acute presentations, which are stroke-like, and what we very often see in this day and age is incidentally detected brain tumors. But some of these are very interesting stories, like a radiology technician who stuck his head into an MRI scanner when the scanner was being calibrated after service and found that he had a meningioma. So once the presence of a brain tumor is suspected based on clinical examination and findings, the diagnosis is established by various kinds of imaging, which includes a CT and MR scans in most cases. Other specialized investigations that are often done include angiography and other imaging like PET and SPECT scans. And to complement this, there are a whole lot of other diagnostic tests that not only not only help to bolster the diagnosis, but also to understand the clinical status of the patient and the derangements caused by the illness. These are some examples of various kinds of scans that we see on a day-to-day basis, and it is important that the neuropathologist be able to understand these scans independently and discuss them with the clinician and the radiologist to understand what the findings are. There are specialized MR sequences that are available now that help us to understand more of the nature of these tumors. One of them includes the magnetic resonance spectroscopy that helps us understand the chemical profile of a lesion that is seen in the brain, and that helps us to guide us whether we are looking at a neoplasm or is it something inflammatory or necrotic tissue or so on and so forth. Once the diagnosis is established, treatment for intracranial tumors follows these trends as you see on the screen. It could be observation. There are some benign tumors like small meningiomas, small vestibular schwannomas, which, if detected early, can be observed because they have a very, very predictable behavior. The mainstay of treatment for almost all types of intracranial neoplasms is surgery. I will discuss about a little more in detail about this in the subsequent slides. But suffice to say that the intent of surgery in this day and age is to try to achieve a maximal safe resection. It is ideal to achieve a gross total resection where the lesion in its entirety is removed, but never at the cost of safety. This, in select cases, is supplemented with radiation therapy and chemotherapy. And as we move ahead in the current era, we are increasingly looking at more specific targeted therapies, many of which have become fairly routine in other systemic tumors, but is still in its very early stages in central nervous system neoplasia. This is something that we keep reiterating now, that at one time, the management of brain tumors was essentially focused on preservation of life. But now it is preservation of function. Just preservation of life is not enough. It is preservation of function. And a lot of our surgical techniques, of our management techniques, are geared towards preserving function as far as is possible. These are some of the tools that we use on a day-to-day basis for management of tumors. Operating microscope is something that every neurosurgeon who operates brain tumors is intimately familiar with. And the current generation of operating microscopes have got a lot of tools that are incorporated with them, a lot of filters that help us to identify tumor tissue from amongst from normal tissue. Image guidance helps us make the surgery more precise and reduces the collateral damage that can arise from misplaced or misdirected surgery. Electrophysiology is very, very routinely used in this day and age to understand neural function, different kinds of electrophysiology that look at the sensory pathways, the motor pathways, cranial nerves. They all help us in identifying the functional areas and tracts and to preserve them. And this is supplemented with an increasing use of awake surgery in many of these tumors, especially some of the tumors that arise that are intraaxial tumors, the glial neoplasms, where the preservation of function, they infiltrate widely into the brain, and the preservation of function is very important. Certain functions like motor functions can be studied even with the patient asleep, but something like language can never be studied with the patient asleep. The patient has to be awake through the procedure, and not only language, but a lot of higher cognitive functions can also be studied with awake craniotomy. This is how an awake craniotomy is, as you see in progress. And this is a very typical scene from our operation theater. Some of these tumors that arise within the neuraxis are sometimes difficult to distinguish from normal neural tissue. As you can see on the image on the top left, the tumor that is just subcortical is very, very difficult to distinguish from the normal tissue. And there we have techniques like fluorescence-guided rejection, where we use fluorophores, certain dyes that are selectively taken up by the tumor. And these, when viewed under ultraviolet light, they fluoresce and they produce this very visible fluorescence that can help guide the surgeon to remove the tumor but stay away from normal tissue. All these, as you can see, are efforts to make the surgery more specific, more focused, and this leads to significantly better functional outcomes for the patient. Moving on to radiation, from the early days of X-rays and undirected photons, radiation therapy has also progressed immensely, where now we have the ability to use stereotactic radiosurgery, where a very focused beam, where radiation can be delivered very precisely to a very, very small area of the brain, very targeted area of the brain. And these, by using different methods, you must have heard of some of these, like the cyber knife, the gamma knife, the X knife, and so on and so forth. And what is in the current buzz, the proton therapy, which uses heavy particles instead of photons to deliver energy to these tumors and to help destroy the neoplastic tissue. So radiation therapy has also progressed immensely. Not only has it made it infinitely more effective, but it has also become far safer for the patient. Chemotherapy, as compared to other systemic malignancies, has less of a role in central nervous system malignancies. However, from the early days of nitrosoureas, the current molecule that is now used is temozolomide. Now, one of the biggest barriers to using systemic chemotherapy has been the blood-brain barrier, which has prevented the entry of large molecules into the tumor tissue in sufficient amounts to cause an action. So temozolomide was one of the molecules that crosses the blood-brain barrier very easily and has been shown to be extremely effective in the management of malignant gliomas in particular. And this also brings us to an interesting point where the damage caused by temozolomide is often repaired by an enzyme called methylguanine methyltransferase, MGMT as it is abbreviated, which is normally present, and that helps to repair DNA damage and limit the damage that temozolomide does to the DNA. Now, this is one of the things that can be tracked. A certain percent of the population have a methylated form of MGMT, in which case the DNA repair is not as efficient as it would ordinarily be. And the damage done by temozolomide to the tumor is much better. So these tumors where there is a methylated MGMT tend to do much better. They tend to respond to temozolomide much better than the ones who are unmethylated. And this is something that can be assayed and is now in this day and age is routinely assayed in malignant brain tumors, where we look at the MGMT promoter methylation status. If it is methylated, the probability of a response to temozolomide is high. If it is unmethylated, the probability of response to temozolomide is low. Now, I mentioned about some of the barriers, about the blood-brain barrier that acts as a gatekeeper, preventing the entry of molecules into the central nervous system, into the interstitium of the central nervous system. So there are ways to overcome this. One is, as you can see in the central panel, there are different ways by which this is done. One is by use of biodegradable implants and wafers that are put into the tumor bed at the time of resection that allows chemotherapy to directly diffuse into the tumor. There are methods like convection-enhanced delivery, where you use a micro pump and you use a convection delivery that goes directly into the interstitial fluid of the CN of the brain and bypasses the blood-brain barrier. There are also other delivery systems. From there, we move on to the newer kinds of therapies that are now available. Some of them, one is photodynamic therapy, where we use, again, certain fluorophores that break down when the exposure to certain frequencies of light and help to destroy tumors. They become active and they help destroy tumors. You have laser interstitial therapy, where you have a laser probe that goes into the tumor and can cause a selective destruction of focal tumors. And the use of focused ultrasound, where the common conventional ultrasound delivers energy in a much higher form than usual, but it's focused to a point, and that can either cause destruction of tissue if the energy delivered is sufficient, or what is now described, the focused ultrasound can be used to reversibly open the blood-brain barrier to allow timed delivery of larger molecules into the brain. All these are neurotherapeutic advances. And from there, we get on to targeted therapy. And targeted therapy, again, is very commonly used in other malignancies like the lung and hemopoietic malignancies, and in the kidney and so on and so forth. But in the brain, like I said, it's still in its early stage. And understanding of the pathological processes, the genetic modifications help to, these are coming in a big way, not only selective blockers, but also things which, therapies that stimulate the immune system, remove immune blockade, like the checkpoint inhibitors, are also being tried out and used in clinical trials in certain kinds of brain tumors. And this is something that we can look forward to in times to come. What are the responsibilities of the neurosurgeon when you do a surgery? One and foremost, as is for any surgeon anywhere, is to provide adequate tissue for examination. The tissue should be representative of the pathology. The tissue should be adequate. And this is very important in central nervous system. Tumors, as we know that many of these tumors can be very heterogeneous, and it is important to collect as much of abnormal tissue as possible, either an en masse removal of the tumor as far as is possible. There are limitations when we operate in the brain to remove a tumor en masse. But when we use tools like the ultrasonic surgical aspirator, the tissue that it fragments and collects can be collected in a trap, and this trap can be sent to the pathologist as one of the specimens for analysis. It is important for the surgeon to sample as many different sites of the tumor as is possible, especially areas that have a different appearance on the preoperative radiology, enhancing areas seen on the preoperative radiology. They all have to be sampled separately as far as is possible. And along with this, what is very important is to provide to the pathologist the detailed clinical and radiological information and the clinical diagnosis and the clinical differential diagnosis. The role of marginal biopsies, which is very common in general oncology, in surgical oncology, is to some extent less relevant here, because the margins of resection are often not decided by the visible margins of the tumor, but based upon the functional tracts that one attempts to preserve, which are often at the margin of the tumor. And this is something that limits the ability of the surgeon to achieve a gross total removal of certain kinds of tumors, especially tumors like gliomas that are infiltrating within the brain. For the pathologist, it is very important that all the available tissue be sampled, not just representative fragments here and there, because again, the heterogeneity within the tumor can make some samples appear low grade, whereas another area might be higher grade. So if the surgeon puts these separately, the pathologist can sample each one of these areas separately. Otherwise, as far as possible, the entire tissue has to be processed. It is mandatory that the pathologist get adequate clinical data before making a diagnosis, before deciding what they are dealing with. And based upon the initial impression, the clinical and the initial histopathological impression, to plan appropriate immunohistochemical and molecular studies. And at the end of this, to provide an integrated diagnosis as complete as possible. Now, there are certain situations where a complete integrated diagnosis may not be possible for various reasons, especially the molecular information, which some of the tests may not be available, or they might be inconclusive, in which case there are categories like NEC or NOS that it is encouraged that is used. And the important thing is to seek external assistance when needed. The availability of markers and certain techniques may not be uniform at all places. So whenever there is a need, it is important to interact with maybe a more experienced pathologist at a different center, or to send the tissue or the slides to another center where further processing can be done. And through this entire process, a constant interaction with the clinician is extremely, extremely important. Now, once the diagnosis is given, this is where the multidisciplinary tumor board kicks in, where the clinicians, the pathologists, the radiologists, the oncologists all sit together, review the the history, clinical findings, the clinical diagnosis, the pathology, the pathological diagnosis, look for a correlation between them, discuss these in detail, agree that this is what the diagnosis is, and based upon the findings, based upon the pathology and the molecular profile, to agree on a course of management. Now, very often in these tumors, now I'm going to be focusing more on gliomas. It's impossible for me to cover all the different tumor types, but my talk will be essentially be focused on gliomas here. Now, the decision making for management in gliomas depends on the pathology and factors like the completion of excision and certain risk factors, especially the age of the patient, the tumor size and extent, the clinical presentation, the radiology. Like, for example, a patient who presents with a tumor who has been having nothing but seizures for a fairly long time and has an occasional seizure, there's a tumor that is picked up. It's more likely to be a more indolent and better behaving tumor, as opposed to a person who has a clinical presentation of seizures rapidly progressing into a neurological deficit with cognitive dysfunction. These are more likely to be more aggressive tumors. And based on the integrated diagnosis, the different morphological types, the WHO grades, and the molecular and genetic profiles which are standard. Now the current iteration of the WHO classification lays out the essential requirements for diagnosis and the desirable requirements for diagnosis, the essential tests and the desirable tests. And these, as far as possible, have to be done. If they cannot be done, the diagnosis of a NOC, of a NOS or NEC will have to be tagged on to the diagnosis, and attempts should be made to complete the essential tests to arrive at the correct diagnostic diagnosis. Now, let me take you through a few examples. This is a 61-year-old gentleman who presented with this large heterogeneous ring-enhancing lesion in the parietal region. Now, from the it is very evident that this is a malignant neoplasm with a peripheral enhancement and a central area of necrosis. This was operated, and as expected, this turns out to be the picture of a glioblastoma, IDH wild type. And this gentleman went on to have chemotherapy and radiation. Another tumor, a young lady who had earlier been treated for a low-grade astrocytoma a few years earlier, was lost to follow-up, but returned with a significant neurological deterioration, and this horrible-looking scan was reoperated, and this again turned out to be a high-grade tumor. Now, this demonstrates something that we know about the CNS tumors, especially the gliomas. Gliomas are notoriously unstable. The lower-grade tumors tend to transform. They have a very high propensity to transform into higher grades spontaneously. So, one thing as clinicians we have realized is the small tumors, the small low-grade appearing tumors, the ones that appear low-grade on radiology, there is no question of waiting and watching on them, because given time, they will grow and they will transform. And as these tumors transform through the grades, the behavior changes, they become extremely aggressive, and the outcomes significantly plummet. It makes a huge difference for the patient. Now, this is a high-grade glioma in tune with the WHO recommendations now. An IDH mutant tumor is not called a glioblastoma any longer, but is called an astrocytoma grade 4. the term glioblastoma is now exclusively used for an IDH wild type tumor. This is another tumor, which is, as you can see here on the images on the left, the pre and the post-operative images. This is a very small frontal tumor that was completely resected. This was an oligodendroglioma, again, the IDH mutant, and to confirm the fish studies were done for 1p19 cube. It was co-deleted and with a very low key index. And this person was advised a follow-up. This person would not require any further treatment, but will remain on follow-up. At some point of time, this tumor may recur, but if it recurs, it will very likely recur as a grade 2 tumor, in which case it can again be safely removed. A similar kind of tumor, but more aggressive. This is a grade 3 oligodendroglioma. Again, IDH mutant, 1p19q co-deleted, but the treatment is different. This patient will certainly have radiation and chemotherapy, even though the tumor is completely removed. They will certainly have radiation and chemotherapy, and the behavior, the outcomes are different from the tumor that you saw on the previous slide. And this is where the difference comes. This is something that's very curious, the ability of the radiology to predict the grade. We believe that the lower grade tumors are more homogeneous appearing on the scan. They do not show contrast enhancement. They are fairly well marginated. As you can see on the left temporal tumor in the images on the top left, which was completely resected. It's a young gentleman presenting only with a couple of seizures. But when the pathology was studied, it shows features of a more aggressive disease, increased cellularity, anaplasia. There is evidence of microvascular proliferation, which indicates that this is transforming into a grade 4 astrocytoma. Even though it's IDH mutant, it's a grade 4 tumor. And even though radiologically this looks like a lower grade tumor, and behavior-wise, this is a low risk, it should be a better behaved tumor, but histologically it is a grade 4 and it will get treated as a grade 4 with radiation and chemotherapy. This is what a thorough search of the tissue, when all the tissue is processed, you find these small fragments, these small changes, which can determine the direction you take the patient on. And when you talk to them and the family, you prognosticate based upon this. One of the problems that everybody faces are these tumors that are deep-seated, that are diffuse, that are difficult to access by open surgical methods, in which case we resort to techniques like stereotactic biopsy, where we put a cannula under either with a stereotactic frame, as is seen here, or under the guidance of navigation, which is also eminently possible in many centers these days, and to obtain a small core of tissue from the tumor. And this is what the surgeon completes a job. Doing the stereotactic or the image-guided biopsy is a very short procedure, can often be done under local anesthesia. The patient is happy, the surgeon is happy, I've done the job, and hand the problem over to the pathologist on a platter. And this is where the pathologist problems begin. A tiny fragment of tissue from a part of the tumor that may or may not be representative of the entire tumor. There is a high probability of misrepresenting the grade, because the area that is biopsied may not be the highest grade area. And this is where, again, the targeting is important. When the surgeon selects a target from which the biopsy is taken, it should be from the area that is either radiologically showing evidence of the highest grade, or if a PET scan is done, which is hypermetabolic. So based on this, the pathologist can sometimes get the small fragment of tissue, which they will find it difficult to make a diagnosis. This is an example of a middle-aged lady who had this small tumor, who had this small lesion that was detected on MRI when she presented with a cognitive decline and a little bit of weakness. And this was initially reported on radiology to be a tuberculoma. Why a tuberculoma? Because it showed the conglomerate rings, small dense rings which are conglomerating, and it seemed to be very typical of a tuberculoma. So this lady was started on anti-tubercular treatment along with steroids and was followed up. 6 weeks later, an MRI showed an enlargement of the lesion with a worsening of the clinical deficit. A few weeks later, there's further enlargement of this lesion. Still with a doubt, a PET scan was done. An FDG PET showed high uptake within the lesion, which is uncharacteristic of tuberculoma, which should be hypometabolic. And this was biopsied with a stereotactic biopsy. And this is what we gave our pathologist, a small fragment of tissue showing a lot of necrosis, even though the biopsy was taken from the edge of the lesion. Going to the center would certainly have only given the pathologist necrotic tissue, but taken from the edge, even there's a lot of necrosis with a very, very scanty amount of viable tissue. This was, after a lot of debate, this very scanty bit of tissue was sent to NIMHANS for further IHCs, and this confirmed that this was a glioblastoma. So these are the problems that the pathologist faces, especially when dealing with these tiny fragments of biopsies. And this is very typical of a situation where the discussion between the pathologist and the clinician is extremely important in deciding the way ahead. The other problem that we now encounter is a problem with recurrent disease, with recurrent tumors. Now, as longevity increases with better primary therapy of tumors, many of these tumors start coming back, and many of them have had treatment earlier with radiation or chemotherapy in addition to surgery. When these tumors are retreated, when they are reoperated, the tissue that the pathologist gets very often is clouded by artifacts from the previous surgery and the radiation therapy. And this can make interpretation of these tissues extremely difficult. And again, one may have to rely on IHCs and other techniques to arrive at a diagnosis as to whether the key is there viable tumor in the tissue that is provided? If there is viable tumor, what is the nature of the tumor? Is it similar to the biopsy obtained at the first surgery, or has it transformed into something else? These are questions that are asked of the pathologist, and they sometimes find it very, very difficult to answer. The newer trends that are now emerging, we have a few of them: the Insitu Diagnosis, the liquid biopsies, methylation profiling, and new generation sequencing. Insitu Diagnosis is expanding in a big way by the use of intraoperative confocal microscopy. We now have a commercial system available that allows us to do from Zeiss, that allows us to do intraoperative confocal microscopy by a probe, as you see on the top right, by sampling the tissue. And this is an in situ sampling. And this throws up new challenges for the pathologists, because they will have to interpret these as they are very unlike the conventional stains, the conventional tissues that they see that are processed with paraffin embedded and hematoxylin using stained on tissue. These are live tissues, very often with fluorescein administration, where there can be a bit of fluorescein there in the tissue, and this is sampled by confocal microscopy. Another way of doing this is by using Raman spectroscopy. This is still experimental, but there are now devices becoming available that allow intraoperative sampling of tissue using Raman spectroscopy. Again, of great help to the surgeon, especially in trying to decide the margins of resection as to whether you are at the margin of the tumor or whether you are veering into normal tissue. Liquid biopsy is again coming up in a big way for many different kinds of tumors, not only to understand the molecular diagnosis and to prognosticate, but importantly on follow-ups to monitor tumor burden and to track diversity and evolution of tumors. In the CNS, liquid biopsies can be obtained either from the blood or from the CSF. There are different things that can be assayed, including circulating tumor cells, cell-free fractions, cell-free DNA, RNA, proteins, and so on and so forth, and extracellular vesicles. There are a whole lot of techniques that are now becoming available that will make this possible. And again, in time to come, I'm sure we can look forward to an increasing use of the liquid biopsy for many of our tumors. The other thing is methylation profiling. Based on DNA methylation profiling, almost all the CNS tumors have been grouped into various methylation classes. And even though the current WHO grading does not include methylation profiling as part of this, it is expected that down the line, methylation profiling will become, as it becomes increasingly available, will become part of a standard to characterize tumors, to characterize certain tumors that are otherwise some that can be quite bizarre into certain classes based upon the methylation profiling. And all this leads into the era of what we call personalized brain tumor therapy, where you understand not only the clinical profile of the patient, but also the molecular landscape in which these tumors arise, the molecular landscape within the tumor and around, the immune profile of the patient. And all these go towards becoming to providing very, very specific targeted therapy. In summary, I can say that neuropathology is a field that's an extremely exciting field in constant evolution. And we are seeing some very, very dramatic changes in the last decade or so we have seen. And these changes are going to continue. We are going to see many more changes that come up that improve our understanding of pathological processes and help us with both the management and the prognostication. Newer techniques have brought about many of these changes. And as ever, the neuropathologist has been, is, and will always remain an integral part of the team that manages CNS lesions. I thank you all for a very patient hearing.
Thank you very much, sir, for the lucid and interesting talk. I think you almost covered all the aspects, and so some of the doubts in the chat boxes also were cleared, I think. One thing I would like to ask you, sir, that the main problem, that is the stereotactic biopsies. Suppose we give it as a infiltrating front of a glioma. So what will be the surgical decision based on this? Because we know that a repeat biopsy is extremely difficult.
Yeah. See, sometimes a problem with stereotactic biopsies is that, see, we tried now when we plan stereotactic biopsies, it is only, so always remember, so you have a tumor here, the probe comes in one axis. So you can sample tissue in one axis only. You cannot sample tissue in different axes. But what we can do is in the same axis, sample tissue at the periphery, at the margin, and within the core of the tumor. So depending on the depth as we go in. Now, ideally, we should get, now when we plan a target, my usual pattern is to obtain one biopsy about 5 to 10 millimeters proximal to the target, at the target, and beyond the target. So you have at least 3 biopsies that you go along. So between these, you should be fairly representative of at least something should be available. But sometimes what happens is when you put in the probe and you take the first biopsy, you encounter bleeding. Now, when you encounter bleeding, the procedure is blind. You do not know what is happening. Unlike an open surgery, we cannot see and control the bleeding. So when you have blood that comes back along the biopsy cannula, you have to stop. Now, this is a time when you can get this peripheral zone and, as you say, very typically an infiltrating margin. Now, if you suspect an infiltrating margin, the next thing to do is to go into IHC and do IDH markers and see whether you get an IDH stain or not. Now, that might help clarify. If you find IDH positivity in that, yes, you are dealing with an IDH positive neoplasm there. But it still remains a problem. Now, sometimes based on a combination of a clinical suspicion, the radiology, and the suspicion of a infiltrating margin on the biopsy, one can go on and plan further management, especially if the lesion is not accessible in any other way. Now, this again is something that is discussed at the tumor board between the clinical profile, the radiology, and the pathologist's impression, and then we decide, are we okay to go ahead with further treatment on the basis of this, or would we need a resampling, in which case we will probably have to go back and rebiopsy it, even though we try to avoid it as far as possible.
Okay. So one more question is there. How relevant are the marginal biopsies, considering the infiltrative nature of glioma, with the tumor cells sneaking between the neurons and native glia, with the limitations of determining the infiltrating front on frozen sections?
Yeah. So, in many areas of surgical oncology, marginal biopsies are extremely important, where the surgeon will keep sending series of marginal biopsies until you get a negative margin. In the brain, this is what I referred to. We know that gliomas infiltrate, and especially with the more malignant gliomas, the infiltrating zone can be as much as 20 millimeters beyond the visible margin of the tumor. Now, doing marginal biopsies again is difficult because very often the margins of resection are determined on both the tumor that's visible on the radiology, the image guidance, but also on the functional tracts. You want to preserve function, so you map the functional tracts and you stop short when you reach the functional tract, like the corticospinal tract, for example. You find the motor cortex, you map the corticospinal tracts, you have a premotor glioma sitting right there. You keep resecting until you reach the functional tracts and you stop. Now, at that point, I would not want to take a marginal biopsy from this, because even if I take a marginal biopsy and I find infiltrating tumor, I'm not going to go ahead and chase it. I cannot. Because if I chase it further, it will mean compromising function. So in the CNS, very often it is a functional parameters, or functional boundaries that determine your margins of resection. So the role of a marginal biopsy in determining the extent of resection is less important as compared to other areas of oncology where you can extend the resection if you get a positive margin.
Okay. Thank you, sir.
Madam, there are a few questions in the chat. Q&A.
You can reduce the number of questions because it's already running late. Okay. Only relevant, one or two you can read.
This much questions are there only there in the chat box.
One question is, how different is management of grade 4 and GBM?
A grade 4 in this day is an IDH mutant tumor, and a glioblastoma is a term given to an IDH wild type. And the management essentially remains the same. It is a combination of radiation and chemotherapy. And the thing is, the IDH status is something that has sort of changed a whole lot of understanding of tumors and their behavior. Because the tumors that are IDH mutant, they tend to be better behaved. They tend to respond a little better to treatment. But the tumor that are IDH wild type, they are extremely aggressive, and their outcomes are quite poor. Similar to that, when we look at an IDH mutant tumor, we also now look at the CDKN2A and B, the homozygous deletion of these, the cyclin-dependent kinase inhibitors. So if there is a homozygous mutation, then it is as good as an IDH wild-type glioblastoma. So if you have a low-grade tumor, one of the examples I showed you was a grade 2 oligodendroglioma, which was IDH mutant and 1p19q co-deleted. Now, in this, if we do a CDKN2AB deletion assay, and we find that this is CDKN2AB, there is a homozygous deletion, this tumor is automatically classified as a grade 4 tumor, and the behavior changes because these tumors tend to behave very aggressively and they are treated with all ways. Now, one of the evolving techniques in glioma management is to try to obtain the molecular profile of the tumor using a stereotactic biopsy or a navigation-guided biopsy at the beginning before one embarks on a major treatment. Now, these are trials that have been tried out, where based on the molecular landscape of the tumor, you start the patient on either chemotherapy or certain kind of targeted therapy that can help reduce the size of the tumor, and then go on with surgery as a second step, something like a neoadjuvant therapy, which is very commonly used in other kinds of malignancies, but less used in the CNS.
Thank you, sir.
Any more question? Any?
I think if anybody has any more questions, you can mail me. My mail ID is available all over. Either reach out to me either on mail or on call, and you can clarify your doubts. I'm available. I'm here. Okay.
Thank you very much, sir.
Thank you again.
Thank you, sir. Thank you very much, sir. Thank from bottom of my heart for taking up your valuable, busy time to be a guest speaker and for enlightening with your presentation, which help us to understand the various treatment modalities, the new trends in diagnosis, like a liquid base on spot diagnosis. So it was really enlightening session. And as you rightly said, sir, the greater the samples we provide or greater we sample will be the greater the accuracy for the neuropathology reporting. And we also understood what are the problems faced by the neuropathologists or what are the problems faced by the neurosurgeons, and a few of your tips like samples the entire available tissue, get adequate clinical data also. And finally you end up with your presentation saying that neuropathologist is an integral part of the management of CNS tumors. So thank you so much, sir, for your wonderful presentations. Thank you, sir. Thank you very much. And thank you, Dr. Neelima, madam, for moderating the session.
Thank you.
Thank you, sir. Thank you, sir. What am I saying?
Now we are going to start the most awaiting session, the slide seminar on neuropathology. Neuropathology is seldom practiced in many centers, so it's still a gray area for most postgraduates and practicing pathologists. In order to ease today's slide seminar and session on neuropathology, that IAPM made a start by conducting a webinar on this topic by 3 esteemed neuropathologists in our country. As we all know, the 5th edition WHO classification of CNS tumor published in 2021 introduced major changes that advances the role of molecular diagnosis in CNS tumor classification. So this live seminar will be very, very useful for each and every one of us. So here we are lucky enough to have 2 eminent pathologists to moderate this live seminar from God's own country who are passionate in practicing the new CNS pathology. So now I welcome Dr. Bindu Ma'am, Professor from Department of Pathology, AIMS Kochi. Madam has done MBBS from Alapi Medical College, DCP from Trivandrum Medical College, and diploma, that is DMB, from Amrita Institute. Her area of specialization is neuropathology and neuropathology. And also like to invite our own Dr. Aparna Madam, who is the Associate Professor in Government Medical College, Kozhikode. Madam has completed MBBS from Calicut Medical College and MD from Trivandrum Medical College. She has done her postdoctoral fellowship in neuropathology from ENHANCE. Madam has many publications for her credit. She is also the chief investigator and co-investigator for many ongoing projects. So over to you, Dr. Bindu ma'am, and over to you, Dr. Aparna ma'am.
Kindly make us the host, the Amrita Institute of Medical Science.
Okay.
Sharing.
Nikhil? Nikhil. Oh, yeah.
Share sound. Optimize video. Share.
The screen is visible. Okay.
The screen is visible. Okay, sir.
Good morning. Myself, Aparna and Bindu, we welcome all of you to the slide seminar on neuropathology. And we thank the office bearers of IAPM and the whole pathology community of Kerala for inviting us as the moderators for this session. As you all know, there's overwhelming increase in the molecular knowledge regarding CNS tumors, and we are also only trying to catch up with that. So please pardon us if there are any shortcomings. And please note that the presentation is not according to the case number. We have made a separate list and we have intimated the judges and the presenters regarding this, just to make the presentation according to the WHO CNS classification, the list of tumors in that, with the very few non-neoplastic pathologies that we got at the ends of the seminar. So without much ado, let's get into the slide seminar. The first case is to be presented by Dr. Karthika Natarajan, that is case number 14. We'll be playing the first part, then we'll project the diagnosis that we got, and then the second part would be played, and after that, the case will be open for discussion.
Okay. Let's escape it. Minimize.
Good morning. I'm Dr. Karthika N, postgraduate student at Government EDMC Alappuzha. I'll be presenting case number 14. This is a case of a 13-year-old boy who presented with fever and chills for 3 days and breathlessness and agitation for 1 day. On examination, he was restless, he had tachycardia and a nasal twang to his voice. The patient had presented to the casualty at 8:30 a.m. His condition exacerbated quickly. was intubated and given supportive measures. However, the patient expired at 12:45 p.m. the same day. His postmortem examination was done at TDMC Alappuzha, and the examination revealed that he had linear scars below the eyebrows. His brain was congested and edematus. All other internal organs were also congested. These are the biopsy images showing 10x view of the cerebellum, 20x view of the cerebellum, 40x view. The case is now open for discussion.
So, the only diagnosis that we got was rabies. All the 18 centers who responded to the questions have given the same diagnosis as rabies. So we'll go to the second part of Dr. Karthika's presentation.
The key points in this case are the young age of the patient, acute onset of symptoms, normal laryngoscopy, and rapid exacerbation. Here are the biopsy images with a 10x view of the cerebellum. 20x view shows many Purkinje cells. 40x view shows a Purkinje cell with a well-defined eosinophilic intracytoplasmic inclusion. 40x view of the cerebrum shows lymphocytic infiltrates. Another area shows perivascular cuffing by lymphocytes. The main differential considered was that of viral encephalitis, with possible etiologies being rabies, HSV, CMV, and subacute sclerosing panencephalitis. In SSPE, the inclusions are intranuclear and the inflammation is predominantly plasmacytic in nature, as opposed to the intracytoplasmic inclusions and the lymphocytic infiltrates in this case. So SSPE was ruled out. In CMV encephalitis, the inclusions can be both intranuclear and intracytoplasmic, but it lacks lymphocytic infiltrates, so that was ruled out as well. Unlike in this case, HSV inclusions are intranuclear and it's also associated with necrosis, plasma cells, and foamy macrophages. So HSV was also ruled out. So we were finally left with a diagnosis of rabies encephalitis. We confirmed this with a direct fluorescent antibody test, which was positive, as can be seen by the fluorescent apple green areas at the sites of antigen-antibody reaction in this image. A rapid antigen test for rabies was also done using brain tissue. It was positive as well. RT-PCR was used to confirm the rapid antigen test. So we arrived at a final diagnosis of rabies encephalitis. Rabies is a virtually fatal disease and most cases occur in the Indian subcontinent. Transmission is via inoculation of saliva through bites. In pediatric cases, the wound may not be reported by the child and it could go unnoticed by the parents. The incubation period is shorter in children. It also depends on the location of inoculation. Bite wounds in the craniofacial areas have the shortest incubation time. In the prodromal stage, the patient might have flu-like symptoms which will rapidly progress to cerebral dysfunction, anxiety, confusion, and agitation. Hallucinations, hydrophobia, and aerophobia are other features of rabies. In this case, a careful review of the patient's clinical history and examination findings was done, and it revealed one instance in which the patient developed aerophobia when he was taken for video laryngoscopy. The microscopic findings that suggest a diagnosis of rabies include mononuclear infiltrates, perivascular cuffing of lymphocytes, lymphocytic foci, Negri bodies, and Babes nodules consisting of glial cells. The biopsy in this case had 4 out of these 5 features. The presence of Negri bodies is variable. It is neither sensitive nor diagnostic because it may be absent in up to 50% of the cases. It could also be confused with other eosinophilic inclusions like those of HSV or CMV. IHC can also be used to demonstrate rabies viral antigen. For the DFA test, the ideal tissue is brain. The antigen-antibody reactions can be visualized as fluorescent apple green areas. PCR can be done to confirm DFAT. It can detect rabies in saliva and skin too. DFAT is the gold standard test for the diagnosis of rabies. It is also the only CDC recommended diagnostic method for routine rabies detection. So the take-home message in this case is that a history of dog bite may be missed in children. The possibility of rabies encephalitis was considered in this case despite the parents denying dog bite in view of aerophobia. Another very intriguing aspect of this case was a recent history of dog bite and post-exposure prophylaxis for his brother, which might have led the patient to conceal any animal contact from the parents out of a fear of injections. A histological finding of Negri bodies helped us to arrive at a diagnosis of rabies encephalitis. This was confirmed with the help of a direct fluorescent antibody test and RT-PCR. Thank you.
Now the case is open for discussion.
Hello. Judges, please note the case is now open for discussion.
Dr. Kartika, are you there?
Yes, ma'am. Yes, ma'am, I'm here.
What are the other samples that you can use for immunofluorescence?
Ma'am, we can use salivary glands, skin, corneal scrapings, etc.
Corneal scrapings and skin are the samples that are set. So any other technique to demonstrate the antigen? Yes.
Negri bodies in histopathology, ma'am.
If you don't see Negri bodies?
Ma'am, if we can't see the Negri bodies, maybe in histopathology we can use IHC,
Yes.
because antibodies
Yes.
against the rabies antigen can be demonstrated using IHC.
So we have IHC is available
Yes,
for
ma'am.
this. And even if we find only 1 or 2 Negri bodies here and then we are not sure of what it is, then we can go in for an IHC.
Yes,
And this is how it would look like. And the other diagnosis that you said, I don't think clinically any of them come, and even at autopsy, like in HSV, you have a particular type of involvement of the temporal lobes, very hemorrhagic, etc. So each one has its own clinical and morphological features. So that also should be taken into consideration.
Okay, ma'am.
So the final diagnosis in case 14 is rabies encephalitis. So we'll go to the, if there are no more questions, are there any more questions?
There's not anything in the chat box, Ani.
Yeah.
No, sir.
Even we couldn't see any questions from here.
And,
There are no questions in the
Dr.
chat.
Vijayalakshmi ma'am have raised a hand.
Okay.
Madam, any questions?
I raised the hand actually to speak to Dr. Dilip, not to the rabies case.
Oh, sorry.
Thank you. Thank you.
Okay, thank you.
Okay.
It's okay.
Okay, then we'll move on to the next presentation.
Okay, ma'am. Thank you.
Okay, so before we move on to the next set of presentations, we all know that the CNS WHO edition 5 is already in the market, and this is actually the 6th version of the international classification for the brain and the spinal cord tumors. And this has come after the 2016 updation of the 4th edition. And working from there and also acquiring recommendations from the C-IMPACT. C-IMPACT stands for the Consortium to Inform the Molecular and the Practical Approach to CNS Tumor Classification. Following the various conferences and deliberations, the knowledge acquired was clubbed and the 5th edition was brought out, which clearly mentions the role of molecular diagnostics in the classification of brain tumors. Having said that, the classification still is firmly rooted to the morphological parameters that has to be taken into consideration for the classification of brain tumors. And like the other tumor in the other parts of the body, in the CNS, we also are moving on from entities and variants to types and subtypes. And the grading was actually happening across the types, like anaplastic astrocytoma and anaplastic meningioma would mean the same, a grade 3 tumor. But henceforth, such grading across the type is not recommended. And also the grading has moved on from using the Roman numerals to Arabic numerals, mainly to avoid confusions. And having said that, the molecular has got its role. The classical example is an IDH mutant astrocytoma, wherein CDKN2A 2B is the homozygous deletion is very important. Irrespective of the morphology, if any tumor which is IDH mutant astrocytoma is seen to show this particular deletion, is invariably classified as grade 4. And this is for the neophytes in pathology, the young budding pathologists who have recently joined. These are the parameters which we take into consideration for the grading of any gliomas. That is the cellularity, the mitosis, the microvascular proliferation, and necrosis. This is the photomicrograph of the microvascular proliferation, where you see the vessels and the endothelial cells proliferating, giving rise to glomerular structures. And this is the picture of palisading necrosis. And since the glial tumors forms the majority of any neuro-oncology practice, this is the comparison of 2016 classification of the astrocytic tumors versus the 2021. As you can see, the classification has largely segregated the pediatric type of tumors from the adult type. This is the major change that has happened. And also the gliomas are classified into circumscribed versus diffuse, and the diffuse is again classified into low grade and high grade. We would be touching upon this as we move with the cases, and as already elaborated by DP sir, IDH is the most important marker, which the IHC of which is widely available. That is the first test to be done in any excuse me, kindly mute, all of you kindly mute. And that's the first test to be done. And any tumor which is recognized as IDH positive, the second test to be done is an ATRX and P53. If there is a loss with a P53 mutation, it's an astrocytoma which is IDH mutant. And the next very important test to be done is a FISH analysis for a CDKN2A/2B. If there is a deletion, irrespective of the morphology, you take it into the grade 4. And when there is a retaining of ATRX, then you have to move forward for the 1P19Q co-deletion. And if it is detected, it is an oligodendroglioma. And this is the pediatric glioma, the classification, which classifies into low grade and high grade. And majority of them, for the complete diagnosis, require a molecular workup. So having said, given such an overview, now we will, is it stuck? Sorry, double click here now.
Madam, you're not audible.
Okay, now we'll move on to the second presentation, the case number 7 from Aster Medicity.
Good morning, everyone. I am Dr. Supriya Menon from Aster Medicity, Cochin, here to present case number 7, the invincible intruder. The case is that of a 32-year-old male who presented with severe headache, vomiting, and memory loss of about 1 month duration. MRI brain showed a heterogeneous contrast-enhancing lesion in the left frontal lobe and caudate nucleus with significant perilesional edema with a radiological diagnosis of intermediate grade glioma. He underwent a left frontal craniotomy. Intraoperatively, grayish vascular suckable tumor with an ill-defined plane from the surrounding brain parenchyma was encountered. Squash smears were reported as grade 2/3 cellular glioma. These are the photomicrographs from the biopsy slides circulated. The case is now open for discussion.
Dr. Supriya, these are the diagnoses that we received from across the state. Kindly note, majority of them agreed for a glioma, which is of the higher grade, and there were a few centers which came up with inflammatory/infective also. Please make a note. And now we will move on with the second part of your presentation.
Sections show a cellular neoplasm composed of diffuse sheets of round to oval and spindle-shaped neoplastic astrocytes with moderate to markedly pleomorphic and hyperchromatic nuclei dispersed in a fibrillary background. Scattered interspersed gematocytes were seen. The tumor showed increased mitosis, including atypical forms and apoptosis. Numerous scattered, bizarre, and multinucleated tumor giant cell forms were also seen. There was no evidence of microvascular proliferation or necrosis in the sections examined. On immunohistochemistry, the tumor cells express diffuse strong GFAP, IDH1R132H. In the hotspot area accounted to about 18 to 20%. And on layered diagnosis, astrocytoma IDH mutant CNS-WHO grade 3 was integrated. As part of management, the patient received concurrent chemoradiation followed by adjuvant chemotherapy, and he was on 3-monthly MRI follow-up. More than a year later, MRI showed a recurrence. He then underwent a left frontal burr-hole placement and navigation-guided biopsy. The second biopsy showed a recurrence of astrocytoma IDH mutant CNS-WHO grade 3. A recommendation for FISH for evidence of homozygous deletion of CDKN2A-B was made. This was done at NIMHANS Bangalore, and the report showed presence of homozygous deletion of CDKN2A-B in the tumor, thus upgrading the tumor. The final integrated diagnosis was astrocytoma IDH mutant CNS-WHO grade 4. Coming to a small discussion, according to the latest CNS-WHO 5th edition, the grading criteria for astrocytoma IDH mutant saw the retention of histological features of anaplasia, mitosis, microvascular proliferation, and necrosis with the introduction of a genetic parameter CDKN2A-B homozygous deletion that connotes a grade 4 designation. Accordingly, grade 3 IDH mutant astrocytomas with no microvascular proliferation or necrosis, as is our case, should and must be tested for CDKN2A-B homozygous deletion. A sneak peek into the novel molecular marker that has gained unbeatable star status, cyclin-dependent kinase inhibitor, encodes for tumor suppressors, and its deletion results in uncontrolled activation of genes involved in the transition from G1 to S phase of the cell cycle, resulting in tumorigenesis. Hence, loss of CDKN2A-B is a marker of poor prognosis and is associated with shorter survival in IDH mutant diffuse astrocytic gliomas. This slide depicts a comparative analysis through WHO grade 2 to 4 astrocytomas, and it clearly emphasizes that there are a number of molecular alterations characteristic of grade 4 tumors. Of these, only homozygous deletion of CDKN2A-B is recognized as an independent marker capable of upgrading a glioma to grade 4 status. It should be noted that these prognostic associations have been validated in prospective cohorts, which explains its inclusion as an independent marker by WHO. The frequency of CDKN2A-B deletions range from 0 to 12% in grade 2 gliomas, 6 to 20% in grade 3 gliomas, and 16 to 36% in grade 4 gliomas. This picture depicts FISH performed using dual color probe kit, wherein the ratio of orange to green signals must be less than 0.8, which indicates the presence of a homozygous deletion. To conclude, an algorithmic approach in the diagnosis of adult type diffuse glioma CNS-WHO grade 2/3 should be adopted, and the tumor subjected to IDH1R132 IHC, which if positive, ATRX and P53 is to be done. Loss of ATRX coupled with P53 positivity should designate a tumor as astrocytoma IDH mutant, and a concurrent CDKN2A-B homozygous deletion should label an astrocytoma as IDH mutant CNS-WHO grade 4, and if it is absent, the tumor should be labeled as astrocytoma IDH mutant either CNS-WHO grade 2 or 3, depending on the histological parameters. On follow-up, less than a year after the second biopsy, our patient succumbed to this deadly neoplasm. Truly an invincible intruder. I thank you all for your kind and patient listening.
The case is now open for discussion.
Hello, good morning, Bindu.
Good morning, madam. Good morning, ma'am.
Yeah, you should, apart from the usage of IHC and all those things, can you highlight the morphological features and tell us or educate us up to what extent we can go on the diagnosis of this tumor?
Madam, morphology wise, the maximum extent to which we can go probably might be to a grade 3 tumor, madam, because there are definitely mitosis there, but we are not seeing any other parameters like microvascular proliferation or necrosis. So maximum diagnosis that we can offer would be a grade 3, madam.
What do you think about that foamy cells or foamy areas?
Yes, definitely. That was noticed by many, and there were some centers which even called it a pleomorphic xanthoastrocytoma. Dr. Supriya, do you have anything to comment here?
Madam, there was definite evidence of features of anaplasia as well as increase in the mitotic activity. Though there was no evidence, it is true that there was no evidence of definite microvascular proliferation or necrosis, but there was definite evidence of features of increase in the mitotic activity as well as areas showing increase in the cellularity as well as features of anaplasia.
Yeah, true. But what do you have to say about those foamy cells? There are.
It could be part of.
Yeah.
Could be part of a degenerative. Yes, there were areas showing the foamy morphological appearance, but considering the mitotic activity in the proliferative component of the neoplasm, so I think we should foresee that and then give more importance to the proliferative part of the tumor rather than the foamy areas because of the proliferation, definitely a proliferating tumor.
Okay, and moreover, PXA is a lesion which is very unlikely to come in that location, right? It is more superficially, yeah, it is more superficially located, cortical based tumor. And definitely this is
plastic PXAs are very rare.
Very rare.
Dr. Bindu, can I intervene?
Yes, sir. Yes, ma'am. Sorry.
Bindu, I don't think there is actually, any possibility of a pleomorphic xanthoastrocytoma because the very presence of so many mitosis is for actually a real high-grade neoplasm like anaplastic. Even though there is no necrosis never there, definitely mitosis was very well shown. And I don't think anybody would go for a xanthoastrocytoma. Just one giant cell I could see other because I'm seeing only these photographs. So I don't think there is any possibility of, pleomorphic xanthoastrocytic tumor.
Okay, ma'am. Thank you, ma'am, for the valid comment. Thank you. And this is the layered report. And Dr. Supriya has very well highlighted the importance of the integrated and the layered reports and the importance of the molecular marker, the novel molecular marker. Thank you for that great presentation, Dr. Supriya.
One comment, Dr. Shankar here.
Yes, sir.
We are confusing grade and survival. IDH is actually indicating survival and not grade. The way everyone thinks is IDH indicates grade. Grade is based on histology, no?
Grading is purely based. No, sir. Grading is purely based on histology, but certain molecular markers take over the morphology. If detected to be present, such tumors are graded 4, and the classical example is this very case.
Would you change the grade based on IDH presence or absence?
No. IDH, no, sir. No, IDH is never taken.
Yes, I think that's clear. Thank you.
IDH mutant, whether they are grade 2, 3, or 4.
Correct. Thank you.
Okay, sir. We'll move on to the third case.
That is from
the
third case is from Government Medical College Trivandrum, presented by Dr. Anjana Paul.
Respected teachers, myself Dr. Anjana Paul, Junior Resident, Government Medical College Trivandrum, presenting case number 8. This is a case of a 29-year-old male who presented with on two aneupleptic drugs. He also complains of semiology, which means all sensation followed by behavioral arrest. On examination, he has no focal neurological deficits and his electrophysiology showed right temporal and parahippocampal region spikes. On MRI, coronal T2 shows a right parahippocampal lesion with multiple cysts and subcortical hyperintensity. Axial flare shows the subcortical hyperintensity and post-contrast 3D shows no enhancement of the lesion. He underwent anterior temporal lobectomy and amygdalohippocambectomy. This is the loper, another loper, yet another loper, and hyper. Now the case is open for discussion.
For this case, we have a whole lot of diagnosis, but all of the centers agree to a kind of oligodendroglioma-like clear cell morphology. Almost all of them. There is plenty, DNET, oligoastro, oligodendroglioma. There was one opinion of a hematoma, then all, and a reactive gliosis. Now we'll move on to the second part of the presentation. Yes.
Can I make a request, Vijayalakshmi ma'am? Kindly please note that your audio is heard in between the presentation. Kindly make it a point that your audio is on mute. A humble request from us, ma'am.
Presenting case of a 29-year-old male who presented with long-standing intractable seizure, which was adolescent onset lasting for past 11 years. The lesion is found in parahippocampal region. Lower image showing uniform population of neoplastic cells arranged in diffuse sheets infiltrating temporal cortex. Tumor infiltrating hippocampus. Cystic change within the tumor. Hyper shows tumor cells with perinuclear halos and mild atypia. High-grade features were absent. We considered oligodendroglioma as our first differential even though adolescent onset is rare. Another histological mimicker we considered was dysembryoplastic neuroepithelial tumor, which usually presents with intractable seizures in this age group. Hence, we proceeded with immunohistochemistry. ODIC2 was positive. TRX shows retained expression. R132H mutant IDH1 was negative and very low proliferative index. Synaptophysin was negative. Performing fish, there is no correlation for 1p19q. Is this oligodendroglioma? Because in young individuals, they are IDH1 negative and there won't be any correlation. Or should we think of an alternate diagnosis? At this point, we came across a new entity called polymorphous low-grade neuroepithelial tumor of the young or plenty, which was first described by Hughes et al., who reported a series of 10 cases arising in young patients aged from 4 to 32 years with associated epilepsy. All cases shared similar features including rounded nuclei with perinuclear halos, infiltrative growth pattern, presence of pseudorosette formation, presence of diffuse calcifications, immune expression with GFAP, OLIC2, combined to diffuse CD34 immunostaining and absent staining with synaptophysin UN and IDH1 R132H. And many of the features were fitting with our case too. Hence, we proceeded with the most crucial immunohistochemical marker CD34, which came out to show diffuse membranous positivity by neoplastic cells. And adjacent cortex shows CD34 positive ramified neural cells. And more, sequencing for IDH12 genes and immunohistochemistry for BRAF V600E can be performed. And finally, we reached to the diagnosis of polymorphous low-grade neuroepithelial tumor of the young or plenty, and we were happy in the fact that it has got an excellent prognosis. On follow-up, the patient is doing well. It is a new entity included in WHO CNS 5th edition under pediatric low-grade gliomas that affect children and young adults. It has an indolent biological behavior with spontaneous onset of epilepsy at young age with cortical localization. Characteristic features include infiltrative growth pattern, histopathological variability, and presence of calcifications. Neoplastic cells show strong diffuse positivity with CD34, GFAP, OLIC2, and retained TRX expression. And absent staining for IDH1, synaptophysin, chromogranin, EMA, and UN. Chi67 is unremarkable. The tumor harbors MAPK pathway alteration, including BRAF proto-oncogene and FGFR2/3, and both were mutually exclusive. This is the diagnostic criteria given in the latest edition of WHO with 6 essential and 2 desirable criteria, and they are fulfilled in our case with available ancillary techniques in our center. They tend to exhibit a benign clinical course and appear to be well controlled by gross total resection. Mostly intolerant, though a single case report of malignant transformation of polymorphous low-grade neuroepithelial tumor of the young was reported in a pediatric patient diagnosed with plenty with FGFR3 TACC3 fusion. These are my references. Thank you.
That was a good case and a good presentation. The case was from SCT and presented by GMC Trivandrum. The case is now open for discussion. Any questions?
Doctor, good morning. Can you just tell us how you ruled out a DNET in this case?
Dr. Anjana?
Yes, madam. Am I audible?
Yeah.
Yeah, DNET, after seeing histology, we consider DNET, and considering the age also, we thought of this DNET. But on second view of the slide, we didn't see any neuronal element that we usually come across in DNET, like floating neurons, mucoid matrix, columnar architecture of a specific glioneuronal element. Such features were absent in this case on second view. We were seeing only this oligodendroglioma-like component. So, and also we, anyway, we did the neuronal marker synaptophysin, and which also came out to be negative. So we ruled out this DNET.
Aparna,
yes, sir.
In the chat box, so many are muted, so it is.
Yes, sir, we are seeing the chat box.
Okay, then it's okay. No.
Any more questions? Anjana?
One question I have.
Okay, sir.
Aparna, can I ask a question?
Yes, sir. Definitely.
This patient has epilepsy, no? So
yes.
What is the epileptogenesis to do with morphology? Is there any correlation or even IDH expression?
Anjana? Yeah, this there are so many characteristic epileptogenic tumors in this young age group, mainly ganglioglioma, pleomorphic xanthoastrocytoma, DNET, angiocentric glioma. So all these tumors have characteristic molecular feature. All these tumors have characteristic molecular features, most of them having MAPK pathway alterations.
My question is the pathogenesis. How does it occur?
Anjana, where is the location of these tumors?
Most of them are located in the temporal lobe.
Yes, has that got anything to do with?
All of them are some superficial cortical tumors.
Is there any change in the brain metabolism produced by some tumors causing epilepsy? See, the point of importance is tackling the epilepsy by anticonvulsants is equally important to removing the tumor.
Yes, sir.
So it's very important to identify which tumors have and identify why they have. There is a relationship to some metabolism is there. I don't remember exactly, some glutamine and metabolism or something is there for certain genetic tumor types. Because of their interference with that they continue to produce epilepsy. So these
that is
people have to be put along.
epilepsy.
I think Aparna, you can explain better that aspect.
Yes, I am also not very conversant on that, but because I don't see these specimens, it has something to do with the amine uptake and things like that. So, but these tumors, the long-term epilepsy-associated tumors or LEATs, they always present with refractory seizures. Unless and until they are removed, the patient does not get relief. There's drug
and I think patient has to be on anticonvulsants for a long period of time, even after you remove the tumor, because of the effect it produced.
Yes,
because of the effect. That is the importance. Thank you. Thank you.
Thank you, sir. Thank you. So the diagnosis, the final diagnosis, is a polymorphous low-grade neuroepithelial tumor of the young or plenty, which is CNS WHO grade 1. And these are the diagnostic criteria. In WHO, we have the essential and the desirable diagnostic criteria. So these are the essential diagnostic criteria. We have the diffuse patterned oligodendroglioma-like cells, the regional CD34 expression, IDH wild type status, and unequivocal expression of BRAF V600E on IHC. And if we don't have these, we can go for a molecular diagnostic evidence of BRAF. And these are the desirable this thing. So Anjana, we have one more question. How will you rule out oligo?
Madam, this oligo, this morphologically, we have oligo as close differential, and when we proceeded with the characteristic IDH and 1p19q, both were negative.
Yes.
And in pediatric cases also, both will be negative. So we were in a diagnostic dilemma.
Okay.
And only the difference, only differential.
Negative, so it rules out an oligo. Then what about glioneuronal hematoma? Have you read about that?
Glioneuronal tumors will be usually positive with this neuronal markers, and those are hamartomas. They are actually disorganized mature neural elements.
Disorganized mature neural elements. They can rarely cause medically resistant epilepsy.
In those cases, only CD34 highlights this ramification of cell process.
Yes, only CD34 will show only the ramification. Here in the tumor, we have CD34 positive neoplastic cells and ramifications of cell processes. Okay, that was a good presentation.
Just one query, Anjana, you said it's a case of a medically intractable epilepsy, and you have not commented about the cortex nor about the hippocampus. What were the findings?
In cortex, we saw some reactive gliosis. And
was there any evidence of dyslamination or dysmorphic neurons?
That is what you should look.
No, madam. No, there is
What
no.
was the status of hippocampus?
Hippocampus also was normal.
Okay, fine.
Then now we'll move on to the next case. At position 4, we have case number 9 from
by Dr. Kavya. To be presented by Dr. Kavya from Jubilee Medical College.
11-year-old child presented with gradually progressive weakness of bilateral lower limbs of 2 weeks duration. On CNS examination, power was reduced in bilateral lower limbs. All other systems were within normal limits. MRI showed an intramedullary intradural mass lesion involving the D8 to D11 segments of spinal cord. Another spherical nodular lesion, possibly a metastatic drop lesion, was noted involving the filum terminale. Patient underwent right hemilaminectomy and decompression. Intraoperatively, a large grey white tumor extending from D8 to L2 segments draping the nerve roots without any plane of cleavage was noted. Grossly, we received multiple grey-brown soft tissue bits, aggregate measuring 0.6 into 0.3 into 0.2 centimeters. These are the photomicrographs of the slide circulated. Scanner view, low power view, high power view, another high power view. Now the case is open for discussion.
Dr. Kavya, these were the responses that we received, more or less agreeing for a astrocytoma or a glioma. We'll now move with the second part of your presentation.
Sections showed fragments of a neoplasm composed of cells arranged in diffuse sheets. The cells showed mild to moderate pleomorphism with irregular hyperchromatic nucleus and moderate amount of eosinophilic cytoplasm in a fibrillary background. Occasional mitotic figures were noted. There was no necrosis or microvascular proliferation. A few ganglion cells were also seen entrapped within the tumor. Overall, the histology picture was in favor of a glioma with astrocytic differentiation. Immunohistochemistry showed a positive GFAP and a Ki67 of 37%. So, our diagnosis was anaplastic astrocytoma grade 3. As this was a case of a child with a diffuse lesion in the midline, the patient was referred to a higher center for further evaluation. From there, an immunohistochemical study for H3K27 mutation was done, which showed a strong nuclear positivity in tumor cell. So the final diagnosis was diffuse midline glioma, H3K27M mutant, WHO grade 4, spinal cord. On follow-up, the patient underwent multiple cycles of chemo and radiotherapy. 6 months later, she presented with a sudden onset of headache and vomiting. CT scan of brain showed multiple metastatic lesions involving the frontal lobe, temporal lobe and the vermis. Patient expired a few days later. Now a few words about diffuse midline glioma H3K27M mutant. It is a new tumor entity established in 2016 WHO classification. It is an infiltrative high-grade glioma with predominantly astrocytic differentiation. It is characterized by mutation in K27 position of histone coding genes H3F3A or HIST1 H3B bar C. It is a WHO grade 4 tumor seen predominantly in children. It mainly affects midline structures such as brainstem, thalamus and spinal cord. It is characterized by a clinical triad of multiple cranial neuropathies, long tract signs and ataxia. It has a dismal prognosis with a 2-year survival of less than 10%. Macroscopically, the tumor shows a diffuse infiltration of the CNS parenchyma, producing a distortion and enlargement of anatomical structures. Microscopically, tumor cells are small and monomorphic but can be large and pleomorphic. They infiltrate and trap normal brain elements. Typically, they have an astrocytic morphology with 10% of the tumors lacking mitotic figures, microvascular proliferation and necrosis. H3K27 mutation can be detected by IHC. Detection of this mutation is sufficient for grade 4 designation irrespective of their histologic appearance or grade. According to the new WHO classification of CNS tumors 2021, this entity is placed under pediatric type diffuse high-grade gliomas and is now referred to as diffuse midline glioma H3K27 altered. We had a similar case of an 18-year-old male who presented with complaints of diplopia, dysphagia and ataxia of 3 weeks duration. MRI brain showed a diffuse expansile lesion in the brainstem. Histologically, the tumor resembled a grade 2 astrocytoma, which on further evaluation turned out to be diffuse midline glioma H3K27M mutant. Both cases were of young individuals with diffuse infiltrating lesion in the midline, having a histology favoring a glioma with significant absence of high-grade features. Take-home messages: all pediatric midline gliomas should be tested for H3K27 mutation irrespective of their morphology, as there are novel emerging therapeutic strategies targeting the same. This is an illustration of the new principle of integrated diagnosis that relies on a combination of genotypic and phenotypic features. These are my references. Thank you.
The case is open for discussion.
Doctor, I have a question. Is there anything in the morphology which supports the diagnosis of this H3K27 mutant glioma as opposed to an anaplastic astrocytoma? Will the nuclei be a bit more darker and more for clumping? Is there anything like that in the morphology? I'm just asking.
Ma'am, morphologically, it can be either, it can resemble a grade 2 or grade 3 tumor. Sometimes giant cells can also be seen in diffuse midline glioma H3K27 mutant, but none of the morphological characters are sufficient for designation of a grade 4 designation. It is only because of the mutation of H3K27 which gives it a grade 4 designation. It is not based on the morphology. Morphologically, we can only grade it up to, even we can even see microvascular proliferation as well as necrosis, but in the absence of microvascular proliferation and necrosis, it can be given a grade 4 designation based on this particular mutation.
Dr. Kavya, suppose you had got that IHC for H3K27 mutant as negative.
Yes,
would you have ruled out H3K27 altered midline glioma?
No, ma'am. Under H3K27 altered, we also have H3 wild type.
Okay.
In H3K27 mutant, the defect is in the trimethylated protein H3K27ME3.
Yes.
So, in H3 wild type can also have a decreased H3K27ME3 protein if there is no overexpression of EC protein and then EGFR mutation. So, we have to rule out both these mutations to give a correct diagnosis as of H3K27 altered. It can be given even in the absence of H3K27 mutants.
Well answered. The role of epigenetics onto tumorogenesis. A classical example is your H3K27 altered, and as Dr. Kavya rightly mentioned, it is not just the mutation that can cause this type. It could be changes that is happening in the polycomb repressor molecules, which enhances the trimethylation of the H3K27. And the WHO 2021 has brought up the essential and the desirable. So to call it a diffuse midline or H3K27 altered, it has to be a diffuse glioma with loss of H3K27 ME3. This is an IHC which will pick up the trimethylated state of the H3K27. It has to be in the midline and there has to be a presence of H3K27 mutation. In the absence of that, it could be due to an overexpression of a ZIP or even an EGFR mutation. And EGFR mutation are more commonly seen in children less than 5 years, bithalamic, all these are, and very aggressive. These are very aggressive set of tumors. So with that, and this is what Dr. Kavya has already answered, and this is the layered report. Again, bringing out the importance of integration of the report into a layered or an integrated diagnosis. Thank you, Dr. Kavya.
Thank you.
Now we'll move on to the next case.
Case
Good
number
morning,
6.
everyone. I am Dr. Vimi Vincent, Junior Resident Government Medical College, Kozhikode, presenting you a case of 7-year-old boy who presented with headache, vomiting, seizure for 8 months, for which ventriculoperitoneal shunt was done. 1 year later, he underwent right frontal craniotomy and excision. Intraoperatively, it was a solid lesion with moderate vascularity arising from the foramen of Monroe with extension to the right lateral ventricle and third ventricle with areas of calcification. Microscopy, scanner view, low power, another area, high power, another area. Now the case is open for discussion.
Most of the centers had a diagnosis of subependymal giant cell astrocytoma, and a few gave a differential of an ATRT, a typical teratoid rhabdoid tumor. Now we'll go to the second part of the presentation.
This is a case of 7-year-old boy who presented with headache, vomiting, seizure for 8 months. There were no relevant past history or family history. He attained developmental milestones normally. He was fully immunized for his age and his perinatal history was uneventful. On radiological imaging, it showed a well-defined lesion in the right lateral ventricle with specks of calcification and intense contrast enhancement on MRI. With these radiological features, these were the differential diagnoses: central neurocytoma, choroid plexus papilloma, and ependymoma. Patient underwent right frontal craniotomy and excision. Intraoperative findings as mentioned earlier. On microscopy, showed a cellular neoplasm which is predominantly arranged as perivascular pseudorosettes. This is the higher power view of perivascular pseudorosettes with focal areas of sweeping vesicles and spindle cells with intervening fibrillary matrix. Cells forming the neoplasm are polygonal cells with abundant glassy eosinophilic cytoplasm, eccentric vesicular nucleus showing moderate nuclear pleomorphism, which is resembling a gemistocyte. There were also few cells which had ganglioid appearance having distinct nucleoli. Occasional large cells and multinucleated giant cells were also noted. The spindle cells had moderate eosinophilic cytoplasm, ovate elongated vesicular nucleus showing moderate nuclear pleomorphism. There were no giant pyramidal-like cells were seen. With these histological features, these were our differential diagnoses: ependymoma, gemistocytic astrocytoma, and subependymal giant cell astrocytoma. Therefore, we proceeded with a panel of IHC in which EMA and synaptophysin was negative, GFAP was focally positive, and TTF1 and S100 was showing positivity in the tumor cells. Our first differential diagnosis was an ependymoma. Ependymoma can occur in children and adults and has intraventricular location. The cells are arranged as perivascular pseudorosette-like pattern. Gemistocyte-like cells can present in ependymoma. But the points which was against ependymoma in our case was there were no true ependymal rosettes, and on IHC EMA was negative. Hence, we ruled out ependymoma. The next differential diagnosis was the gemistocytic astrocytoma. The only point which was in favor for our case was gemistocyte-like cells. Gemistocytic astrocytoma usually occur in adults as an intraparenchymal lesion. Ours is a 7-year-old child with intraventricular tumor. GFAP is only focally positive, where in gemistocytic astrocytoma we can see sheets of GFAP positive cells. Hence, we ruled out gemistocystic astrocytoma. The other differential diagnosis was a subependymal giant cell astrocytoma. It is usually associated with tuberous sclerosis complex and it occurs in children as an intraventricular lesion. Cells are usually arranged as sheaths, sweeping vesicles and nest. Our case had predominantly a perivascular pseudorosette-like pattern. Marked nuclear pleomorphism, giant pyramidal cells and multinucleated giant cells are very common in cases of SEGA, but these were very few and scattered in our case. And on IHC, GFAP was focally positive and TTF1 and S100 was positive in the tumor cells. By keeping all these features in mind, child was evaluated for other features of tuberous sclerosis. No other features were found. And on extensive literature search, we could find that rare cases of SEGA has been reported without any other clinical features to suggest tuberous sclerosis, but most of them have developed other stigmata of the disease on later part of their life. So correlating with the radiological, histological and immunohistochemical findings, we arrived at a final diagnosis of subependymal giant cell astrocytoma WHO grade 1. According to 2012 revised tuberous sclerosis complex consensus conference, they have given genetic and clinical criteria to diagnose tuberous sclerosis. In this case, we could not do genetic testing for the pathogenic mutation in TSC1 or TSC2 gene. But according to the clinical criteria, SEGA is one of the major feature. Since this patient doesn't have any other clinical feature, this case could be a possible case of tuberous sclerosis. Now the child is under regular follow-up and now he is doing well and on anti-epileptics. Coming to the discussion. Subependymal giant cell astrocytoma is a periventricular tumor composed of large ganglionic astrocytes. It arises in the wall of the lateral ventricle. It has got strong association with tuberous sclerosis syndrome with an incidence rate of 5 to 15%. It is due to the biallelic inactivation of TSC1 or TSC2 gene. SEGA in the absence of tuberous sclerosis has been reported, which may harbor currently an undetectable TSC gene alterations like low-level somatic mosaicism or large deletions. TTF1 is a marker of fetal medial ganglionic eminence, which indicates that SEGA originates from the ventral forebrain structures. Take-home message is that subependymal giant cell astrocytoma should be kept as a differential diagnosis for the ventricular lesions in the pediatric age group, even in the absence of other features of tuberous sclerosis. TTF1 is a useful IHC marker to differentiate SEGA from its morphological mimics. These are my references. Thank you.
The case is now open for discussion.
Doctor, I have a question to ask. Will you consider gemistocystic astrocytoma as a morphological diagnosis? Gemistocystes, aren't they supposed to be smaller with an eccentric, darker looking nucleus, whereas in this case, you had clearly gangliocytoid astrocytes?
Dr. Vimy? Dr. Vimy, are you there?
Hello, Dr. Vimy.
She's there. I think her mic is also on. I'm not sure. Not able to hear anything. I think she left.
She left. Probably she's trying.
Yes, ma'am.
We'll just give a few seconds to her because.
Avarna, you can continue with the discussion. Any questions in the chat box? Like that? Okay, he's not there.
It had to be answered. So.
Oh, right.
Okay, then it's fine. Can I answer that question? Actually, gemistocystic astrocytoma is only a rare differential. Yeah,
she's come.
She's back.
Yes.
Errors, ma'am. Can I hear the question? One more? Yeah, gemistocystic astrocytoma, ma'am.
Yes.
Yeah, there were gemistocystic-like cells on the gemistocystic cells on the microscopy, but other points was not in favor to a diagnosis because it's usually seen in adults as an intraparenchymal lesion, and GFAP will be strongly positive for that cases. But in our case, IHC was only focally positive. But since it's showing some gemistocystes on the microscopy, we just had a differential as a gemistocysite for this case.
Now, I want to know morphologically whether you will think of these cells as gemistocytes when they clearly have a large nucleus with a nucleolus.
Some of them are having that ganglioid appearance, ma'am, but not all the cells are not having that prominent nucleoli on the microscopy. There were large cells having that eccentrically placed nucleus and so.
Can you tell why they are gemistocytes? What does that word mean?
I don't know, sir, actually.
Gemistocyte is derived from the word gem. Gem means fill up, I think in Greek or something. So it is filled up with this intermediate glial filaments, you know. So much it is bursting with them. So they'll be very strongly GFAP positive. That's how you pick up these cells. They can be seen in reactive conditions also, especially anoxia, I think, some acute ischemic injuries, you will see reactive
type of,
and also as a part of tumors like you see here. So you don't pick up a gemistocyte simply by morphology, like the nucleus or nucleolus. You have to see these filaments. They may contain other proteins also. I think you can see them in tuberous sclerosis and certain other conditions when they may be filled up by other proteins, not just glial fibrillary proteins. It's just a morphological appearance where the cell is filled up with these glial proteins or other proteins. That is how you call that. There is nothing like, you cannot say gemistocytic astrocyte. You can say gemistocyte. It's probably an astrocyte which is filled with these things.
Yes, sir.
So let's not debate on gemistocyte because that itself is not very clear.
Vimi, could you tell any other useful IHC marker?
TTF1 is a very useful marker to differentiate from the mimics. And another marker that can be used as a neural stem markers like nestin SOX2.
No, not for the diagnosis. Any other useful marker?
Useful marker for what, ma'am?
What is the pathway that is activated in SEGA?
mTOR pathway.
Yes. Any
tuberin and hamartin complex. So we can do tuberin or hamartin IHC.
Yes. mTOR pathway. For mTOR pathway, which is the IHC that can be used? Phosphorylated S6. And why do you want to know? Because there will be reduction in tumor volume if you use mTOR inhibitors like everolimus.
Everolimus, yes.
Okay.
Dr. Vimi, there is one question in the chat box. How do you rule out ATRT histologically?
Yes, ATRT was in the differential diagnosis.
ATRT, the predominant pattern will be a rhabdoid pattern, and on IHC it will be EMA positive. But our case EMA was negative, so we didn't consider ATRT.
Okay, getting back to the radiology, will the radiology help in the situation?
And it's predominantly seen intraparenchymal lesion, not in the ventricles. Most commonly seen
Intraventricular ATRTs are also described. Dr. Vimi, intraventricular are also described, but will the radiology help in the situation?
It's a well circumscribed altered, and there's an intense contrast enhancement to the lesion. But in ATRT, it is usually in hypodense lesion, I guess, ma'am. I'm not sure about it.
Okay, ATRT is aggressive, so it has to have all aggressive features on radiology, which will be contrast enhancing with perilesional edema, high level of infiltration into the neighboring structure. So all these necrosis,
diffusion restriction because it's a highly
cellular
tumor. Okay.
Yes,
okay.
What is subependymal nodule?
Subependymal nodule is a precursor lesion of subependymal giant cell astrocytoma. You can see it's a very small, less than 5 mm tubers on the white matter as a candle dripping on the imaging.
So these are the essential and desirable diagnostic criteria for SEGA. And subependymal nodule, she has already described the size. And in SEGA, there will be growth over time, whereas subependymal nodules remain as such, but there are instances of progression to SEGA. Okay, so thank you, Vimi. We'll move on to if there are no more questions, we'll move on to the next case.
Please note the next case is by Dr. Shubha MS, case number 4 from Rajagiri Hospital.
Good morning. I am Dr. Shubha MS, DNB resident Rajagiri Hospital. I am presenting case number 4. A 1 year 10-month-old female child presented with history of seizure following fall. MRI showed a heterogeneous lesion with solid and cystic component in right frontal lobe with patchy meningeal thickening and enhancement. EEG showed right frontal spike and slow discharge and right frontotemporal slowing. Left frontal craniotomy and total excision of lesion under GA done. Microscopy, low power. Another field. Another field. Higher power. Another field. Now the case is open for discussion.
Okay, Dr. Shubha, these were the responses that we got. Majority, almost 18 centers diagnosed it as desmoplastic infantile ganglioglioma, with a few coming up with a pilocytic. Somebody even called it a neuroblastoma SFT. Now we'll move on to your second part of the discussion and come back for the.
Okay, ma'am. Coming back to our case, a 1 year 10-month-old female child presented with seizure following a fall. Radiologically showed a heterogeneous solid and cystic lesion in the frontal lobe with leptomeningeal thickening and enhancement. Radiological DD given were infantile glioblastoma, desmoplastic infantile ganglioglioma, and pleomorphic xanthoastrocytoma. Left craniotomy with complete excision of the lesion was done. Grossly we received irregular gray white tissue aggregate measuring 4.5 into 4.2 into 3 cm with attached meninges. Microscopy, low power showed a well delineated neoplasm with solid and cystic areas and extension into the subpile space. Higher power showed a desmoplastic stroma composed of spindle cells arranged in storiform and fascicle pattern, interspersed with neoplastic astrocyte with mild nuclear pleomorphism. Also seen in areas, cells with abundant eosinophilic cytoplasm, vesicular nucleus and prominent nucleoli. Differential diagnosis considered based on morphology were desmoplastic infantile ganglioglioma, ganglioglioma, gangliocytoma, and glioma with entrapped neurons. Special stain. Reticulin stain demonstrate marked desmoplastic stroma. Immunohistochemistry was done. GFAP was positive in the neoplastic astrocyte arranged in streams and was negative in the desmoplastic stroma. Synaptophysin highlights the ganglion cell. And desmoplastic stroma was demonstrated by positive vimentin. Summarizing, a neoplasm well delineated from normal brain involves the subarachnoid space and extends into Virchow-Robin spaces composed of neoplastic neuroepithelial cells in desmoplastic spindle stroma arranged in fascicular and storiform pattern. IHC, GFAP highlights neoplastic astrocytes, marked desmoplastic component demonstrated by vimentin, and synaptophysin highlights the ganglion cells. And the diagnosis given was desmoplastic infantile ganglioglioma, WHO grade 1. Discussion. It is first described by Vandenberg et al. In 1987. It is a benign glioneuronal tumor. It is a rare intracranial tumor of early childhood with a male to female ratio 1.5:1. Usually arises in supratentorial region. Enlarging head circumference with tense bulging and fontanelle was the most common presentation. Radical surgical resection is associated with long-term disease-free survival. Comparative genomic hybridization didn't show a consistent loss or gain, but in few cases BRAF V600E mutation was seen. Dissemination of these tumors through CSF has been reported rarely. These are my references. Thank you.
The case is now open for discussion.
Hello, excuse me. Doctor, I do not know whether it is possible in this age group, but histologically, wouldn't pleomorphic xanthoastrocytoma be a diagnosis in this case? Especially there are huge xanthoma cells, and this reticulin fiber that you described around cells is also possible in PXA, this leptomeningeal involvement of the subpial space or whatever. And I think there can be neuronal positivity also sometimes because these astrocytes can differentiate into neuronal cells. So how will you? And there were plenty of lymphocyte collections. I think it's not seen in desmoplastic infantile ganglioma. So can you just explain it?
Hello, ma'am. Am I audible?
Yes, yes.
Ma'am, there was a characteristic feature was a striking feature was a desmoplastic stroma, and interspersed by the neoplastic astrocytes, and also synaptoviscin was positive in ganglion cells, which are not a feature favoring for a pleomorphic xanthoastrocytoma. And the reticulin special stains, pericellular distribution of the reticulin stain, it also favors towards the desmoplastic infantile ganglioma.
Okay. Shubha, there were huge xanthoma, cells, huge cells with plenty of vacuoles in the cytoplasm, abundant lymphocyte collections, which are unusual in DIG. So is it also seen in DIG, these kind of cells? You haven't shown them in your pictures. I don't know. Can you see lymphocyte aggregates like this?
Usually, a mononuclear infiltrate is usually rarely seen in desmoplastic infantile ganglioma. But synaptophysin was demonstrating the ganglion cells.
Yeah, that's strong synaptophysin phosphate.
And stroma was demonstrated by the vimentin, and astrocytes, also neoplastic astrocytes, demonstrated by the streaming GFAP arranged in streams, all favoring for desmoplastic infantile ganglioma.
Shubha, what is the incidence of PXA in this age group, your patient's age group?
It is low incidence, ma'am.
Usually, young adults and second and third decades you get to see, isn't it? And moreover, if you look at the case, you have a very characteristic desmoplastic component which is like attached to the dura. It has an extra cerebral location, and that happens more in a DIG. You don't get to see such a desmoplastic component which is the outermost part of the tumor in a PXA. Yes, and Dr. Shubha, I could also see some areas like this. These are definitely not lymphocytes, but these are cells which are smaller, something looking little primitive.
Can you elaborate on that?
There were areas like this in the slides circulated. This is
the picture we have taken
from the slide. Yeah.
It is usually sometimes the desmoplastic infantile ganglioma, they are associated with the poorly differentiated components.
Yeah, you can have it. You can have a primitive component like this. Suppose this area comes as the major component. What will you then like to rule out?
DNet has to be ruled out?
No, suppose this particular component, you said you can have a primitive cell as a component in a DIG. Suppose this forms a majority. Would you like to entertain some other differential in that situation? There is one new entity called isomorphic infantile glioma or astrocyte hemispheric glioma, which is described with these kind of primitive looking immature cells. But then here your radiology is the catch. This is actually a cyst with a mural nodule in a young child with such a desmoplastic extracerebral component, and the tumor cells you can see in areas, it's actually trickling down the Werker-Robin spaces. So all these are very
seen on your slide.
Yeah.
You did not show a photograph.
So all these are very much characteristic of your diagnosis. Okay.
Okay.
So these are the essential and the desirable criteria given in the WHO. So you would see a biphasic morphology with a dominant desmoplastic leptomeningeal component admixed with neuroepithelial component, which would contain sometimes only astrocyte, then you call it by the name DIA. And if it contains astrocytes and neuronal cells, it's a DIG. And in cases where it is not resolved, you might have to go for a methylation profile, like a BRAF or a RAF1 mutation or a fusion, which might be occurring in the absence of homozygous deletion for CDKN2A. That is very important, because suppose you see a mutation or a fusion for a BRAF and also in addition a CDKN2A bar 2B homozygous deletion, it qualifies for a pleomorphic xanthoastrocytoma. So that is the carry home message from this case. Thank you, Dr. Shubha.
Thank you, ma'am.
Just one comment I have to make here. Can I?
Yes, sir, please. Yes, sir, please.
Desmoplasia or form of collagen formation. Desmo means connective tissue. It can occur in brain only from two places. One, meninges, and second, the vessels.
Yes, sir.
None of the neurons or the glial cells can produce this. So unless the tumor infiltrates the meninges, very rare to get desmoplasia.
Yes, sir.
So
Yes, sir.
desmoplasia can be seen in any tumor which involves the meninges. It's a type of reaction of the meninges to come. It's not actually a part of the tumor.
Yes.
Tumor. I was just interested seeing that this is a small round cell tumor, WT1, and whether you should do the profiling of WT1 and CD99, whether it would be going into that pathway. Have they mentioned something like that?
No, sir, not to our knowledge, sir.
Because as we know, desmoplasia is a feature of such tumors, Ewing's, desmoplastic, small round cell tumor of childhood, etc.
Yes, sir.
Just thinking of the morphology, I was just thinking whether that has to be done.
Yeah, that is food for thought. Thank you.
Thank you, sir. Yeah.
Now we'll go to the next case. At position 7, we have case 5 from Government Medical College, Kottayam.
I am Dr. Anne Maria Sunny from Government Medical College, Kottayam, presenting case 5. Female 7-year presented with headache, vomiting of 3-week duration. Her sensory and motor system were within normal limits. Lab investigation also showed normal values. MRI showed a large mass in the intraventricular aspect of left lateral ventricle, suggestive of neoplastic etiology. Subtotal excision done. The gross specimen received were multiple friable gelatinous soft tissue pieces. Photomicrograph circulated, scanner view, clear cells and bands of fibrillary material, cells with darker nuclei. Now the case is open for discussion.
So here we had a whole lot of different diagnoses. Okay, yes. We have one more slide. We couldn't fit all those into one. So all these were there. So basically, people thought of a clear cell tumor, a clear cell component to the tumor. All these tumors have that clear cell component. So now we'll go to the second part of Dr. Vinny's, Dr. Anne's case and see what she has to say.
Section of brain showing a vascularized neoplasm composed of predominantly clear cells arranged diffusely. There were pools of basophilic material in between the cells. Clear cells have abundant cytoplasm, small round dense central nucleus, and resemble oligodendroglial cells. There were clusters of clear cells separated by pilocytoid bands of fibrillary glial tissue, in which were embedded large cells with abundant cytoplasm, resembling ganglion cells. Interestingly, this highly vascular neoplasm also showed blue cells, which were clustered around vessels and also in the midst of clear cells. Here, you can appreciate the difference in nuclear size between blue cells and clear cells. High power of these blue cells showed nuclei with stippled chromatin, possibly neuronal. microvascular proliferation and mitosis seen. No necrosis. Now the question is whether the neoplasm is glial, neuronal or mixed. These were the differential diagnoses based on histology. Oligodendroglioma was considered because of clear cells. A vascularized neoplasm with clustering of tumor cells around vessels made clear cell ependymoma a differential. Same so with neurocytoma and intraventricular tumor. We also thought of glioneuronal tumor owing to the presence of both glial and neuronal component. ISC done. Bright GFAP positive fibrillary background seen in clear cell areas. Pilocytoid bands were GFAP positive and so were the ganglion-like cells. The clustered blue cells were synaptophysin and NSC positive, indicating neuronal origin. Ki67 showed 20%. Presence of positive neuronal markers ruled out oligodendroglioma. EMA was negative and absence of true rosette ruled out clear cell ependymoma. Though central neurocytoma is capable of glial differentiation in small proportion, abundance of glial component as in this case ruled out neurocytoma, pointing the fingers to a glioneuronal tumor. These are myxoid glioneuronal tumor and diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters. Both are new entities described in WHO 5th edition. Both occur in pediatric population, have unique methylation profile, and an oligodendroglial and neuronal component. Myxoid glioneuronal tumor is characterized by a myxoid background in addition. These are the references which describe myxoid glioneuronal tumor. GFAP is positive in this entity and pilocytal morphology has been described for glial component. A lateroventricular mass in a 7-year child with both glial and neuronal component in a myxoid stroma, presence of positive glial and neuronal markers with Ki67 20% favored a diagnosis of myxoid glioneuronal tumor with high proliferation index. Patient presented with recurrent symptoms 2 months later. The tumor board decision was repeat surgery. In 2021 WHO classification of CNS tumors, a set of tumors with unusual morphological features were brought together on the basis of a specific DNA methylation profile. These tumors are stated to be low-grade with a more homogeneous behavior. Literature has so far reported only a few cases of myxoid glioneuronal tumor. Our case showed high Ki67 index and microvascular proliferation consistent with a high-grade tumor as evidenced by early recurrence. Further studies are required to characterize the behavior and course of this class of tumors. These are my references. Thank you.
The case is now open for discussion.
Any questions?
Okay.
Dr. Anne?
Yes, madam.
What about the synaptophysin in the oligodendroglial-like cells?
It was negative, madam.
Yeah, you didn't show that because that is a relevant point for the diagnosis of myxoid glioneuronal tumor. Synaptophysin in the oligodendroglial-like cells.
Yes,
why did you consider a diffuse leptomeningeal glioneuronal tumor?
Madam, in that the MRI will show the diffuse leptomeningeal thickening.
Can it
Such a
occur
find
outside the leptomeninges? Then how would you refute this diagnosis of pylomyxoid astrocytoma?
in that there is a neuronal component in addition to the pilocytoid component.
Can
In our case,
synaptophysin be positive in this tumor, pylomyxoid or pilocytic astrocytomas?
rarely only, madam.
Rarely it can be positive. Okay. Any more questions? Okay, so this is the tumor. So we had these myxoid areas, some perivascular arrangement of tumor cells, these oligodendroglia-like clear cells, and as she said, there was a higher grade component which is not described in myxoid glioneuronal tumor. We did an IDH immunohistochemistry which is negative, ATRX was retained, and OLIC2 was diffusely and very strongly positive in this tumor. And FISH for 1p19q was negative, ruling out a oligodendroglioma. So here we have a glioneuronal tumor with a myxoid stroma, clear cells, ganglioid astrocytes, small cells with neuronal differentiation, and a perivascular arrangement. So this was actually a difficult nut to crack. Me and Bindu, we had a lot of discussions on this case. So finally, we are thinking of something in between a myxoid glioneuronal tumor and a diffuse leptomeningeal glioneuronal tumor. This diffuse leptomeningeal tumor can occur without a leptomeningeal component, like parenchymal examples are described. This is in the ventricle, of course, and these are the essential and desirable criteria. And in unresolved cases, we have to resort to methylation profiling of these tumors. Even in this, it is mentioned, myxoid, in the note given below, it is mentioned that we should resort to methylation profile of DLGNT. So that is this tumor.
And moreover, Dr. Ann, you said the patient has come back with recurrence in a very short span of time, right?
Yes, madam.
That itself says that it is an aggressive tumor. So
Yes,
when we look at the literature, the myxoid glioneuronal tumors are indolent, and less than 100 cases are reported in the literature, and nowhere it has been mentioned as an aggressive tumor. So
whereas this
DLGNT
is known for its recurrence.
Recurrence and an aggressive behavior. Definitely, this is a case which warrants a molecular categorization and further workup. And since your tumor board has decided for a resurgery, I think
we can get more material and do a methylation profile of the same.
Probably we can get help from the pioneers in the field from our country, and we together should try our best to resolve this issue. That is what for us this is a glioneuronal tumor which is aggressive in nature.
Yes.
We couldn't, in spite of doing all these homeworks, we both were not able to resolve. Dr. Neelima and Anita madam joined us in this journey. They also helped us with IDH, and OLIC2 was done from Aster. And actually speaking, the block was almost getting depleted. So there wasn't enough tissue also. So all the more it is important, if at all a resurgery is going to be done,
preserve tissue
for molecular workup. That is the consensus of opinion.
But chromosomal 1p deletion was negative, no, in this case?
It is negative. It is negative. Negative. It is negative.
Yeah, and then in the desirable criteria, you do not have leptomeningeal involvement also.
Yes.
So isn't that also a difficult diagnosis, DLGNT?
Yeah, definitely, ma'am.
Differential, ma'am. There are intraparenchymal examples of DLGNT without a leptomeningeal component.
Very rare case reports are there, and the essential criteria specifically mentions, though they say that chromosome 1p deletion and the MAP kinase alteration, like the fusion with the KIA1549 is described. For those unresolved cases, they say methylation profile is only the answer.
Yeah, methylation profile will be the only answer. But
yes,
look at morphology, these kind of pilocytoid bands, which are very well seen in this particular tumor, with embedded gangliocytoid astrocytes.
Yes,
I think was described only for this particular entity, myxoid GNT. And diffuse glioneuronal tumor with oligodendroma-like areas is also a definite histological DD, but that is always GSD
clusters. Madam, that doesn't come and that doesn't actually come as a morphological differential. Myxoid, definitely this is a glioneuronal tumor with myxoid. So much of myxoidy areas, but the only, or maybe the striking feature is the mitosis, the microvascular proliferation and increased proliferation, and the recurrence itself speaks that it is a aggressive tumor. So we need to work on this.
So thank you, Dr. Ann. Now I think we'll move on to the next case.
From GMC Thrissur by Dr. Vinny KP. Judges, please note this is case number 3 from Government Medical College.
Junior Resident, Government Medical College Thrissur, presenting case 3. This is a case of 10-year-old male child who presented with headache for 10 days. His MRI brain revealed left parieto-occipital cystic lesion with mural nodule measuring 4.2 into 3.3 into 3 cm, pilocytic astrocytoma. These are the HND images. Now the case is open for discussion.
These are the differential diagnosis that we got. Again,
yeah.
The people thought of a high-grade tumor with an oligodendroglioma morphology.
Yeah.
So we'll go on to the second part of the case.
Detailed clinical history. This is a case of 10-year-old male child with no developmental delay who presented with headache and vomiting for 10 days. His MRI brain revealed a non-enhancing cystic and solid lesion with mural nodule at left parieto-occipital region measuring 4.2 into 3.3 into 3 cm. Ventricle seen separate from the lesion, pilocytic astrocytoma. These are the MRI images. Microscopy, scanner view, section from brain shows a vaguely circumscribed neoplasm. Another scanner view. Low power view shows a neoplasm composed of cells arranged in sheets. Capillary sized blood vessels noted in an arborizing pattern in between two muscles. Another area shows neoplastic cells arranged in pseudorosettes. High power view shows monomorphous population of cells having moderate amount of cytoplasm, round central nucleus, salt and pepper chromatin, and perinuclear clearing. Mitosis noted 13/10 high power view. Another high power view. Areas of necrosis noted. So with the clinical history and morphological features, we have the following differential diagnosis: atypical extraventricular neurocytoma, anaplastic oligodendroglioma, and anaplastic ependymoma. Anaplastic oligodendroglioma, which is a very rare tumor in children. It is a diffusely infiltrating glioma composed of rounded hyperchromatic nuclei with perinuclear halos and also with high mitotic rate, palisading necrosis, and microvascular proliferation. It shows positivity for ATRS, GFAP, OLIG2, S100, and negative for NSC and synaptophysin. Anaplastic ependymoma occurs both in children and adults. Arrangement predominantly in pseudorosettes and rosettes, composed of relatively small uniform cells in fibrillary matrix. Cells have scant cytoplasm with round nuclei and high NC ratio. High mitosis and palisading necrosis will be seen. Positive for GFAP, S100, Y19, and negative for NSC and synaptophysin. We proceeded with the immunohistochemistry. Tumor cells shows diffuse positivity for synaptophysin and NSC. K67 index shows approximately 45% in hotspot areas. Tumor cells were negative for GFAP and chromogranin. Tumor cells were negative for Y19 and S100. Since GFAP, S100, Y19 were negative, anaplastic oligodendroglioma and anaplastic ependymoma were ruled. So, with the morphological features and IHC, we came to a final diagnosis of atypical extraventricular neurocytoma. Coming to extraventricular neurocytoma, central neurocytomas are tumors located within intracerebral ventricles. Tumors within CNS parenchyma and share same histological features are termed as extraventricular neurocytoma. Common age group extends from 1 to 79 years. Median age is 4th decade of life. Predominant site is cerebral hemispheres. It is about 71% of cases, among which frontal lobes are most common. Symptoms varies according to the location of the tumor. Seizures, headaches, visual disturbance were common in cerebral extraventricular neurocytomas, whereas patients present with symptoms of raised intracranial tension in thalamic and hypothalamic locations. Salient microscopic features are Arrangement is predominantly in honeycomb, sheets and rosettes composed of monomorphous cells with round nuclei and speckled chromatin. Hyalinized vessels and calcification may be seen, positive for synaptophysin and graded as WHO grade 2. The term atypical has been used for lesions with an elevated mitotic rate and Ka67 proliferation index. It is generally a benign tumor and has low rate of recurrence if it is totally resected. 1p19q co-deletion is a poor prognostic factor. About related research works, limited information on extraventricular neurocytoma in pediatric population has been reported. The current case report presents a rare example of an atypical extraventricular neurocytoma in a 3-year-old girl. So take-home message is, although rare in pediatric population, atypical extraventricular neurocytoma must be included in the differential diagnosis of a cystic mass in the cerebral hemispheres in children. These are my references. Thank you.
The case is now open for discussion. Any questions? Would you consider a neuroblastoma in this case? Because the child is very... Dr. Vinny?
Madam.
Would you like to consider a neuroblastoma in this case?
Age-wise, we can consider, madam.
But
morphology
is not fitting.
Okay. But neuroblastoma, you have to have small round cell population, but neurocytic differentiation, all that is described. But again, probably your radiology, all that will help in the situation. I think you have covered all the aspects of this particular tumor. This is just one IDH, since the criteria describes a negativity for IDH R132H. I got an IDH done, which is negative. This is the diagnostic criteria for the extraventricular neurocytoma, essential being extraventricular neurocytic tumor without IDH alteration, synaptophysin expression, and for unresolved cases, methylation profile. So it's very well giving the essential criteria. And the desirable is the classical fusion. And if you look at the intraventricular neurocytoma, no characteristic molecular alteration has been described. And if you look at that, the TTF1 expression is also described for an intraventricular neurocytoma. So I really wonder, though they carry the same name, are they really same, or do they take their origin from different cell lineage? This is my thought process when I was like looking at this case. I think that's all for this particular case, and the diagnosis is atypical extraventricular neurocytoma. Looking at the morphology, definitely this will go for a grade 3. Thank you, Dr. Vinny, for that good presentation.
Now we'll move on to the next case, which is from by Dr. Anjali Jose from Amrita Institute of Medical Sciences.
A very good morning. I am Dr. Anjali Jose from Amrita Institute of Medical Sciences, Kochi, presenting case 10. History: 21-month-old toddler presented with 2-week history of gradual progressive weakness of the left upper and lower limb with 1 episode of vomiting, with a single episode of generalized tonic-clonic seizures at the age of 1 year. On examination, the child was afebrile, conscious, oriented. The tone and bulk was normal in all the 4 limbs with a power grade 3 in the left upper and lower limb, and the child was not ambulant. MRI done showed a right frontoparietal contrast-enhancing intraaxial mass lesion with a subcortical cyst with a severe mass effect and a midline shift. So the clinical differentials that were considered at that point of time was a pilocytic astrocytoma, supratentorial PNET, gangliocytoma, and a high-grade glioma. The child underwent a gross total resection of the tumor, and peroperatively the tumor was firm, very vascular, with a clear plane of demarcation between the tumor and the white matter. Grossly, we received multiple gray white tissue bits in aggregate measuring 5.5 into 4 into 1 centimeter. These were the photomicrographs taken from the slide that were circulated. This is a low power view. This is the high power view. The case is now open for discussion.
These are the differentials. These are the differentials that we got. Many of them had a diagnosis of clear cell ependymoma. Again, a clear cell tumor with differentials like this. So we'll move on to the next part of the presentation.
Moving back to the case. Microscopically, the tumor showed cells arranged in diffuse sheets with intervening chicken wire-like vasculature with extensive areas of calcus spherules. The cells have round to ovoid nucleus with a speckled chromatid. With a clear perinuclear halo, there were no evident mitosis, necrosis, or microvascular proliferation seen. On the basis of morphology, a diagnosis of an oligodendroglioma, WHO grade 2, was made. IHC done showed tumor cells were diffusely positive for GFAP, Vimentin, S100, and Q was 2 to 3% positive. EMA done at that point of time was found to be negative. On the basis of morphology as well as the IHC findings, a diagnosis of an oligodendroglioma grade 2 was given. The case was discussed in a multidisciplinary tumor board and several discrepancies were raised. The first was an oligodendroglioma at an age of 1.5 years, which is extremely rare. Also, the tumor had a clear line of demarcation as against an oligodendroglioma, which usually have an infiltrative borders. Because of these reasons, the remaining scan tissue was processed and showed areas like where the cells were predominantly arranged around perivascular acellular zone. Several articles have been published in the literature which states clear cell ependymoma as a mimicker of an oligodendroglioma. Keeping that in mind, EMA was repeated as per an expert opinion of the neuropathologist by adjusting the pH and showed the tumor cells with diffuse dot-like positivity. So on the basis of morphology as well as the IHC findings, a diagnosis of a clear cell ependymoma WHO grade 2 was made. 10 years down the lane, our toddler who underwent a gross total resection without the requirement of any adjuvant is now 11 years and is in 5th standard and is doing extremely well without any kind of recurrences. With the advent of the new evolving molecular classifications of the ependymoma, we thought that our child warrants a molecular workup. According to the latest WHO 2021 classification, ependymomas are now primarily defined by their anatomic location, that is the supratentorial compartment, the posterior fossa, the spinal compartment, the histological grade, and the molecular features. The DNA methylation profiling of the ependymal tumors identify 9 distinct molecular subgroups, 3 within each category, that is the supratentorial, the posterior fossa, and the spinal compartment. Our area of interest was in the supratentorial compartment that primarily carries the ZFTA fusion or the RELA fusion, the YAP1 fusion, and the others which is included in the NEC and the NOS categories. Molecular workup of our patient was done and L1 Chem as a surrogate marker of RELA was negative. Interface fish analysis with RELA break-apart probe was done and showed the tumor cells with normal yellow signals indicating a normal RELA gene. Interface fish analysis using dual color YAP1 break-apart probe was done and showed the tumor cells with isolated red and green signals indicating an unbalanced YAP1 rearrangement. So our final integrated diagnosis was a supratentorial ependymoma, YAP1 fusion positive. When compared to the supratentorial ependymomas that carries a ZFTA or the RELA fusions, the ones with the YAP1 fusion, as in our case, are more commonly found in young children, that too predominantly girls, and usually carries a favorable prognosis. To conclude, the case is a clear example which demonstrates that the clinico-radiological correlation, the histopathological classification, along with the molecular categorization of the ependymal tumors into 9 distinct subgroups has led to a more refined characterization of the clinical course and the potential molecular targets. These are my references. Thank you.
Now the case is open for discussion. First of all, I should congratulate Bindu for being so persistent with this case. I remember selecting this case for my previous slide seminar 9 years back. So this case is there older than 10 years. She said the toddler is now 11 years. So this is really persistent effort and a very well worked up case and a good presentation. Any questions?
No questions. I just want to congratulate. Excellent job, moderator Bindu and Aparna, for including this case with 9 years follow. Wonderful, really amazing. Thank you.
Thank you, ma'am. Means a lot to us.
just one small morphological point I would like to make. We should, when you see this kind of clear cell tumors in very young population, we should look for these kind of subtle points like this perivascular rosetting of the tumor cells to people who don't have any IHCs and things like that. They should keep this clear cell ependymoma in mind and look for these subtle changes. And these are the diagnostic criteria for IAPM fusion positive supratentorial ependymomas. She has explained it very well. I don't think there is much need to go into a detailed presentation. And this is the integrated diagnosis, supratentorial ependymoma, IAPM fusion positive. This has a better prognosis. Now we'll move on to the next case, which is at position 10.
By Dr. Asila from VPS Lakeshore Hospital.
I am Dr. Asila, second year DNB resident of VPS Lakeshore Hospital, presenting case number 11 of a 4-year-old boy presented with complaints of imbalance while walking and tilting of head to one side for the last 1 month. There were no history of seizures, ENT bleed, headache or vomiting. MRI showed a mass in the right CP angle of size 4.3 into 3.9 into 3.4 cm with compression of fourth ventricle and partial effacement and dilatation of third and lateral ventricle. The imaging differentials considered were ependymoma or vestibular schwannoma, for which patient underwent suboccipital craniotomy and subtotal tumor excision. These are the microphotographs of biopsy in scanner view, low power view. Now the case is open for discussion.
So, Dr. Asila, these are the diagnoses that came across to us. Majority for an embryonal tumor with multi-layered rosettes, and some majority are with an embryonal tumor. Some have told it as an embryonal tumor, possibly ETMR to do IHC for LIN28. So probably we can move on with the second part of your presentation.
Yes, ma'am. So in summary, 4-year-old boy who presented with the mass in the right CP angle for which underwent suboccipital craniotomy. Perioperatively, there were no definite plane identified between tumor and brainstem, hence only internal decompression done medially with subtotal tumor excision. At the time of surgery, the possibilities surgeons considered were ependymoma buried into brainstem or a brainstem glioma protruding out. These are the microphotographs of Scotch smear showing sheets of undifferentiated cells displaying scant cytoplasm and central round nuclei with several rosettes formation. So we rendered a frozen section diagnosis of embryonal tumor. Our permanent sections also confirmed the frozen section diagnosis of embryonal tumor, showing fragments of a high-grade neoplasm in varying cellularity, and the cellular areas composed of small round bolus cells alternating with loosely cellular area in a background of neuropathic stroma. And the most striking feature was the presence of rosettes formation, both true and pseudo rosettes, as you can see in this high power view. Based on these morphological features, we arrived at our differential diagnosis of embryonal tumor with multi-layered rosettes, posterior fossa ependymoma with anaplastic features, medulloblastoma, CNS neuroblastoma, and although the morphology was not typical, we considered the remote possibilities of a brainstem glioma and a typical teratoid rhabdoid tumor considering the age of the patient. On proceeding with the IHC, the glial markers GFAP and OLIC2 were negative, IA and I1 showed retained expression, thereby excluding the possibilities of a glioma and atypical teratoid rhabdoid tumor. EMI was also negative, so chances of ependymoma was felt to be less likely. Synaptophysin showed strong diffuse positivity with a Chi67 proliferation index of approximately 80%. And based on this immunohistochemical profile, we narrowed down our differential diagnosis to embryonal tumor with multi-layered rosettes, medulloblastoma, and the rare CNS neuroblastoma. And finally, we proceeded to the specific molecular marker LIN28A, which is a surrogate marker for molecular alterations in ATMR, which showed strong diffuse positivity in our case. So we arrived at our final diagnosis of embryonal tumor with multi-layered rosettes, WHO grade 4. Our patient deteriorated 2 months post craniotomy. Repeat MRI showed residual right CP angle tumor with multiple leptomeningeal deposits and drop metastasis. These are the 2 consecutive MRI which we have taken in the time period of 2 months with the regrowth of the tumor as you can see in the second scan. And the patient was started on craniospinal irradiation, but unfortunately our patient's secondary disease 6 months later on. ATMR is extremely rare and highly aggressive tumor recently introduced in the 2016 WHO classification of the central nervous system tumors. Only 211 cases of ATMR have been reported till date. Initially, embryonal tumors were classified under primitive neuroectodermal tumors of the central nervous system. Later, embryonal tumor with abundant neuropil and true rosettes, ependymoblastoma, medulloepithelioma with similar histological feature and molecular alteration at chromosome 19 were identified by Pfister and Koshner, and they were classified under an umbrella term embryonal tumor with multi-layered rosettes C19MC altered, but with identification of several other molecular alterations, the genetic modifier has been removed and now renamed as embryonal tumor with multi-layered rosettes in the upcoming 2021 WHO classification of the central nervous system tumors. ATMR affects children under 4 years of age, with the most commonly located in the supratentorial hemisphere. And the most characteristic morphological feature is the presence of multi-layered structures composed of pseudostratified neuroepithelium with central neuropil. And the majority of the patients with ATMR have an amplification at chromosome 19q13.42, which can be diagnosed either by immunohistochemistry using LIN28A or by fluorescence in situ hybridization. Approximately 20% of the patients present with leptomeningeal spread. Majority of the patients die within 1 year of the diagnosis. So in a nutshell, ATMR is a rare and aggressive tumor. Diagnosis is based on ISC or fluorescence in situ hybridization. Multimodality approach consisting of radiotherapy and chemotherapy is usually preferred. Local recurrence and distant relapse are common. These are my reference. Thank you.
The case is now open for discussion. Any questions? If there are no questions, I would like to ask you one question. Dr. Asila, can you have other tumors which could be LIN28 positive?
Yes, ma'am. In other embryonal tumors like atypical pterygoid tumors and some germ cell tumors can present with LIN28 positivity. But they all show a focal positivity. But in our case, like ETMR shows widespread positivity.
Yes.
What is the difference between the rosettes in ependymoma and this entity? True rosettes?
In ETMR have a central neuropil, and whereas in ependymoma the rosettes are empty, madam.
What about the layering?
Layering, in our case, there is a multi-layering of the rosettes with mitotically active.
Typical multi-layered rosettes. Whereas in ependymoma, you get more of a single-layered rosettes. That is one point, subtle point for the.
And also highlights the utility of INI1. Whatever morphology, if it is from a child, a pediatric case, you have to go for an INI1. That is the strongest message that one should acquire from this case. Well presented, Dr. Asila. We'll move on to the next case. Case number 12 to be presented at position 11 by Dr. Shruti Surendran from Malabar Cancer Center.
I am Dr. Shruti Surendran, DNB resident from Malabar Cancer Center, Talasheri. Today I am presenting a referred case of a 14-year-old girl who was evaluated for recurrent headache and blurring of vision for 1 year. Radiology shows a pineal tumor with hydrocephalus, and the patient underwent endoscopic ventriculectomy followed by craniotomy and gross total decompression. These are the microscopic images showing scanner view, low power view, high power view. Now the case is open for discussion.
These were the differentials that we received, mostly concentrating on pineal parenchymal tumors. Now we'll go to the next part of the presentation.
Now coming to discussion part under microscopy, scanner view shows a cellular neoplasm composed of blue round cells arranged as sheets embedded in fibrillary matrix. In low power view, we can see that our tumor is a cellular neoplasm arranged as sheets embedded in a fibrillary matrix, and some fibrous vessel delineating the tumor cells are seen, and our tumor has scant to moderate cytoplasm and round to oval nucleus with fine chromatin, and some shows hyperchromatic nuclei. These are high power view showing pleomorphic cells and delineating fibrous vessels, and we have only scan mitotic figures. So our differentials include pineal parenchymal tumor of intermediate differentiation, pineocytoma, pineoblastoma, atypical teratoid and rhabdoid tumors, and central neurocytoma. From the morphology itself, we can exclude pineocytoma, pineoblastoma, and central neurocytoma. And pineocytoma is a rare neoplasm. It is a well-differentiated tumor. It has bland cytology as that of a pineal gland, and they are arranged as sheets and pineocytomatous rosettes. Next is pineoblastoma. Pineoblastoma is an embryonal neoplasm. It is a poorly differentiated neoplasm, and the cells have high NC ratio and high mitotic activity, and it has necrosis. Next is central neurocytoma. Central neurocytoma arises from tumor of septum pellucidum, and it has well differentiated neuronal features like ganglion cells and fibrillary matrix. Next, we have some outside IHCs which shows diffuse positivity for synaptophysin. OLIC2 and GFAPs are negative. INI1 shows retained nuclear expression, and MIB1 is 12 to 15%. From our institution, we have done synaptophysin which shows strong diffuse positivity, and Ki67 index is 10 to 12%. For concluding our case, from the radiology, we found that our case is a pineal tumor with hydrocephalus, and from the morphology, we found that our tumor lies in between pineocytoma and pineoblastoma. In pineocytoma, the tumor cells have bland cytology as that of histology of the pineal gland, and they are arranged as sheets and as rosettes. They are only have scan mitotic figures. In pineoblastoma, it is a poorly differentiated tumor. They are arranged as sheets or some with rosettes, and they are round to oval, and highly pleomorphic cells will be there, and it has high mitotic activity and necrosis. And our tumor lies in between these two because it has both bland cytological features and scan mitosis, and as that of pineoblastoma, it has scattered pleomorphic cells. There is no necrosis, and mitotic figures is very low. Ki67 index is 10 to 12%. Next, from the IHC, we ruled out other differentials, that is OLIC2 and GFAP came out to be negative, and we ruled out glial neoplasms. Next is INI1. INI1 shows retained expression from the outside IHC, and from that we can rule out a typical teratoid rhabdoid tumor and desmoplastic myxoid tumor of pineal region. Next is synaptophysin, which shows diffuse positivity, and it is in favor of pineal parenchymal tumor of intermediate differentiation. And also Ki67 is 10 to 12%. It is also low because in pineoblastoma, usually Ki67 will be more than 25%. So, our diagnosis is pineal parenchymal tumor of intermediate differentiation. It is a rare disease, first classified by WHO in 2000. It is intermediate in malignancy between pineocytoma and pineoblastoma. It is more differentiated than pineoblastoma. It has pleomorphic cytology, and optimal management for this disease has not yet been determined. These are some of the textbook pictures of pineal parenchymal tumor of intermediate differentiation. First picture shows a radiological finding of pineal parenchymal tumor which impinging the ventricles. Next is histology showing pineal parenchymal tumor of intermediate differentiation. They have fibrous vessel delineating the tumor cells. And third picture shows the pineal parenchymal tumor of intermediate differentiation having bland cytology arranged as sheets and as rosettes. These are my references. Thank you.
The case is now open for discussion.
Any questions? Dr. Shruti?
Yes, madam.
Yeah, what is a marker that can be useful in differentiating this tumor from central neurocytoma, both are synaptophysin positive? Any other marker neuronal marker?
Yes, new N can be positive
can be used because it is the central neurocytoma shows more of neuronal differentiation, so that can be used. And is there any grading system?
Madam, the grading system is not yet to be defined, but it comes under grade 2 and grade 3 in between these two, because in grade 2
within the tumor, within the PPTID.
Yes, within the PPTID, it comes between 2 and 3, because some tumor have less than 5% mitosis, and some have more than 5% mitosis.
Yes, so the marker which is said for you useful for this differentiation?
NFP is more overexpressed in grade 2 tumors and less expressed in grade 3 tumors.
Differentiated.
Yes.
Okay. So two morphological patterns have been described, which is diffuse or neurocytoma-like and pseudo-lobulated. That was the one she was trying to explain about fibrous vessels. You have to use the word lobulation. Vaguely lobulated tumors.
Okay, madam.
And this is the grading, Jouvet's grading for PPTID into low grade and high grade using mitosis and neurofilament positivity. And features correlating with biological behavior are proliferation rate and degree of, that's why we are using this grading system. And regarding proliferation index, this in 2 it can be low, that is 5.2 and versus 11.2 in high grade tumors. And of course, as we said, expression of NFP is inversely proportional to aggressiveness. And this is a hallmark paper on this, in which they have described two morphological variants. One is a large cell variant and the other one is a small cell variant. What we got now would be a small cell variant, and that has overlap with pineoblastoma. And that is why many reports of pineoblastoma in adult population was given. Maybe there were small cell examples of PPTIDs. These large cell ones are have a lot of pleomorphism and more of matrix in them. So any more questions? Or we'll wind up this case and go to the next case in position 12.
From Asta Mims, Kozhikode.
One second. I want to.
Yes, sir.
It's an area of discussion because we are now defining a tumor with intermediate differentiation. What do you mean by intermediate? I don't understand. Differentiation can be to one side or the other side. Is it not? See, I have seen cases of pineocytoma which have de-differentiated into pineoblastoma in metastasis into the spinal cord. Long times, many times I have seen that. So the primary tumor may be one, the metastatic tumor could be the de-differentiated part in the primary tumor. So every tumor may have a part which is possibly it can de-differentiate into its blastic component. That's very well known. No, plasmacytoma and plasmablastoma like that. Some are, of course, de novo like that. So where do you put this tumor? Is it borderline malignant, or is it benign?
That is, these group of tumors, I think nobody is sure of them. It's not fitting into pineoblastoma or pineocytoma regarding the prognostic aspect.
Yes, even the WHO, the latest one, hasn't come to a consensus on that, sir. So
they
those
are all arising from the pinealocytes. That is the only cell available. No, from that only it can arise. There is no other cell there. So it should be a tumor from that, but the morphology may be somewhat partly this and partly that. Could it be one tumor de-differentiating or one tumor differentiating? That is something, because always neuronal we think of differentiation and de-differentiation.
Yes, sir.
Till we justify that, putting that into an intermediate grade tumor is always risky. That's what my personal feeling is that. Because suppose a patient has got a pineocytoma and you get a pineoblastoma metastasis through the CSF into the spinal cord. What will you call that tumor? Will you call it intermediate like that? At the beginning, will you revise the first one as intermediate? These are some of the points to ponder,
Yes, sir. Sir, can I add one point there, sir?
Sure.
Probably it would have been an aggressive tumor to begin with. These are located in areas where it is difficult to access. So the amount of tissue that come across to us is also very little. So that may be one reason. Yeah,
that can be there even for any tumor. You can say like that, but this is a consistently observed phenomenon, not one case. You read up the literature. Pineocytoma de-differentiating into pineoblastoma has been described. When such an entity is existing, such a de-differentiation is possible, like in a chondrosarcoma. Why do you want to put in an intermediate entity? I don't know. Somebody may have thought of this, but it's just for people to ponder.
Yes.
I am not sure about bringing a borderline tumor into brain tumors. It will create a lot of confusion for people like me who follow basic behavior of tumors and the cell of origin and the histogenesis, etc. So there is no logic. I don't find the logic that you get some high Ki index immediately you put a borderline tumor like that. That's not correct. Unless you follow up these patients for maybe 10 years and see how it grows, you cannot reclassify like that. If you go on reclassifying, you will end up reclassifying what you did earlier again and again and again. I don't know how you can call borderline tumors in the brain. Such a thing has not been described in any other part, to the best of my knowledge. So let's go to the next case, but this is for people to ponder.
Yes, sir. Sure. Well taken, sir. Thank you, sir.
So, Dr. Bindu. Good morning, everyone. I'm Dr. Neshahel, DNB resident in
Sir, madam.
Calicut, presenting case number 1.
Madam.
This is a history of 58-year-old male without any comorbidities, history of craniotomy.
Vijayalakshmi, madam. Sorry, we had started to play the video. We have paused it, ma'am. What was the point that you wanted to make, ma'am? Vijayalakshmi, madam. Am I audible to you?
Yes, madam.
Okay, shall we proceed with the presentation then?
You can.
Okay.
Good morning, everyone. I'm Dr. Neshahel, DNB resident in Calicut, presenting case number 1. This is a history of 58-year-old male without any comorbidities. History of craniotomy and excision of tumor in left frontal base was done in 2015. In 2021, recurrent frontal lesion was detected on follow-up MRI. His general examination, neurological and other systemic examination were normal. Basic investigation were also within normal limits. MRI brain showed recurrent lesion in the left frontal convexity, anterior fox and frontal sinus. Bone invasion identified in left frontal region and orbital roof. This is the low power view. This is the high power view. This is another low power view. Now the case is open for discussion.
Okay. Dr. Neshahal, these were the responses. Vast majority coming up with a clear cell meningioma with a few reports of clear cell renal cell carcinoma metastasis as well, and some people have called it an atypical meningioma also for obvious reasons. So we may go back to your presentation, part 2.
It was a 58-year-old male, detected recurrent frontal lesion on follow-up MRI. His general and neurological examination were normal. Patient proceeded with craniotomy and tumor excision, and the specimen received in pathology department. Grossly, it was multiple fragments of grey-brown tissue together measuring 4 into 3.3 into 1 centimeter. Low power view shows a neoplasm composed of cells arranged as sheets and diffusely. High power view shows cells have vesicular hypochromatic nuclei, occasional distinct nucleoli, and moderate to abundant clear cytoplasm. No mitosis or necrosis seen. This is a low power image showing brain invasion. EMA done, it was positive. Ki-67 proliferation index was 15%. This is the previous biopsy of same patient in 2015. Low power image showing a neoplasm composed of cells arranged diffusely. High power view shows cells have vesicular hypochromatic nuclei and moderate to abundant clear cytoplasm. Final diagnosis is recurrent clear cell meningioma, WHO grade 2. Clear cell meningioma is a rare condition, constitute 0.2 to 0.8% of all meningioma. It is more common in young patients. Mean age group of involvement is 29 years. There is high chance of recurrence and mortality as compared to other tumors with grade 2 morphologies. There is higher association with SMARCA1 mutation. Next, about histological features, it has a patternless or sheeting architecture of clear cell. Prominent perivascular and interstitial collagen may be there. It may not display characteristic meningioma features like whorls, psammoma bodies and intranuclear inclusion. It has a strong predilection for spinal cord and posterior fossa. Special stains PAS positive and diastase sensitive. IHC positive are EMA, PR and Vimentin. According to WHO 2021 classification, the essential diagnostic criteria for meningioma are classic histopathological features matching at least one of the meningioma subtype or suggestive histopathological features combined with the biallelic inactivation of NF2 or other classic drivers of conventional meningioma like TRAF7, AKT1, KLF4, SMO, PIK3CA, or for clear cell meningioma, SMARCA1 mutation or rhabdoid meningioma, BAP1. Or suggestive histopathological features combined with one of the defined DNA methylation classes of meningioma. The desirable diagnostic criteria are dural or meningeal localization, EMA immunoreactivity, strong and diffuse SSTR2A immunoreactivity, and classic copy number alteration of NF2 mutant meningioma. Meningioma grading according to WHO 2021. A typical WHO grade 2 meningioma means high mitotic index more than or equal to 4/10 hypofield, at least 3/5 soft criteria like sheeting, spontaneous necrosis, macronucleoli, small cells and hypercellularity, and brain invasion. Anaplastic or malignant WHO grade 3 meningioma means extensive mitotic index more than or equal to 20/10 hypofield, frank anaplasia like carcinoma, sarcoma or melanoma like features, TERT promoter mutation and CDK into a homozygous codeletion. These are the WHO grade 1, grade 2 and grade 3 tumors. Patient was treated with radiotherapy after surgery. Now he is doing well. Thank you.
The case is now open for discussion.
I would just like to tell that in the slides, there were definitely areas where there were small whorls with, this meningothelial-like cell appearance, the classical nuclear feature.
Agreed, ma'am. Yes.
And
Yes.
the thing is, we would have thought of it as a classical entity, but this age group, 58 years, is supposed to be quite unlikely for this.
Yes, ma'am. Yes, ma'am. Agreed. Yes. But definitely there were areas, as you said, which would make anyone think of a meningioma because of the classical whorls there and the intranuclear clearing and all that. Dr. Neshahel, what were the special stains which were expected to be done on this case?
PA is positive, ma'am. And diastase may be sensitive.
Okay.
Anything else? Especially in clear cell meningioma? What is the peculiarity?
I think you have described in your histopathology slide. There is something which is very conspicuous in the stroma that is described, collagenization happening. Yeah.
Perivascular and interstitial collagens will be there.
Yes.
Yes.
So which stain? Okay.
Yeah. And
micro.
Yeah. So this was one area from the slide given. There was an area of necrosis also.
For the novice, this is the kind of necrosis that you see in meningiomas. You won't see like in other tumors, small areas of spotty necrosis that you see.
Okay, and then this was the PAS done by us. PAS was strongly positive, which was taken sensitive, yeah. And this is, like Madam said, these are the classical whorls that we saw. And this is the Mason's trichrome done. This is from the periphery. There were no collagen bands separating it out. Tumor cells, yeah. There were no.
We didn't find that, but morphologically under the HND, we thought there were some findings.
Yeah. And since if at least a few have come up with a diagnosis of a renal cell carcinoma, in this particular case, this may not be a tough situation because you have the characteristic whorls. But then you should always remember meningioma is a tumor which is known to receive metastasis. So that has to be a thought process. And this is one article which clearly says the utility of CD10, CN9 and RCC antibodies to distinguish or distinguish these two entities. But then you should be always cautious in interpreting these markers, CD9 and CN9 especially, in case of a clear cell renal cell carcinoma, metastasis will be very, very diffuse. Whereas in a meningioma, this can come, but it will be very focal. So that is a point to be taken. So Dr. Neshahel has already told about this essential and the desirable criteria, but then a long time ago, we relied so much on Ki-67 for the to understand the aggressiveness of meningioma. Gone are those days, and in our institute, we have already started doing a third mutation analysis in all meningiomas, because your mitosis, your Ki-67, they don't actually predict the outcome. So if a meningioma is seen to show a third mutation, it has to be considered as an aggressive meningioma irrespective of the morphology. And one more point to be added is that in the latest WHO 2021, meningioma is considered as a single type with those 15 already described morphological as subtypes. So it's only a single entry in the CNS classification. So with that, we will move on to the case at the 13th position, which is case number 2 to be presented.
One small comment to make for the postgraduates. We have talked of clear cell ependymoma and clear cell meningioma. There is one difference. Whereas clear cell ependymoma, the clear cell is an artifact. Clear cell meningioma, it is not an artifact.
Yes, sir.
As we have proved by PAS.
Yes,
this
sir.
point has to be noted, the difference between the two. Thank you.
Thank you, sir. Thank you, sir. Case number 2 from RCC.
I am Dr. Pravanya PK, Junior Resident, Regional Cancer Center, Trivandrum, presenting case number 2. 55-year-old female presented with memory impairment since 4 months, weakness and numbness in both right upper and lower limbs for 4 to 5 weeks. MRI showed 2.9, 2.1, 1.9 centimeter lobulated cortical juxtacortical lesion involving the left anterior frontal lobe with thick peripheral ring-like post-contrast enhancement and surrounding edema. Left frontal craniotomy and gross total resection of the tumor was done. Grossly, the tumor was nodular, cut surface gray-white myxoid with foci hemorrhage and small cysts. These were the photomicrographs, scanner view, low power view, high power view, another high power view. Now the case is open for discussion.
These were the differentials that we got. All of them agree on a spindle cell lesion and a myxoid appearance. So that is why chordoid, myxoid, then the vascular component. So now let us go to the next part of the presentation.
Coming to the discussion, more areas of tumor showing brain parenchyma with relatively circumscribed, moderately cellular neoplasm with cells arranged in lobulated pattern. Showed varied morphology with fusiform to spindle cells in abundant myxoid basophilic matrix. Areas showing cells arranged in codes, microcystic change and vascular proliferation in a myxoid stroma. Higher power view showing clear and epithelioid cells with mild atypia. Few foci of necrosis seen. Differentials considered were chordoid and microcystic variants of meningioma and solitary fibrous tumor with myxoid areas. On immunohistochemistry, tumor cells showed variable expression for EMA, strong positivity for vimentin, negative for STAT6 and GFAP. CD34 highlighted vascular endothelium only. So can this be a meningioma? But the radiology was not favoring meningioma. On discussion with the radiologist, their impression were high-grade glioma or metastasis because this is an intraaxial tumor with minimal dural attachment and massive peritumoral edema, which is not usually seen in meningioma. So we did thorough literature review and came up with a new entity with similar morphology and proceeded with further IHCs. Tumor cells showed patchy strong expression for desmin and diffuse strong expression for SMA. CD99 showed diffuse strong cytoplasmic and membranous positivity. MIP 4 to 7%. Reticulin stain showed intense pericellular reticulin pattern. To summarize, tumor cells positive for EMA, vimentin, SMA, desmin and CD99. Negative for GFAP, STAT6 and CD34. So a diagnosis of mesenchymal neoplasm with myxoid stroma, features compatible with intracranial mesenchymal tumor was given. To confirm our diagnosis, we proceeded with fluorescence in situ hybridization, which showed break-apart signals indicating positive translocation involving EWSR1 gene. Intracranial mesenchymal tumor with FET-CREP fusion is a provisional entity included in WHO classification of CNS tumors 5th edition 2021, which is first described in 2017. This tumor has been variably described in literature as myxoid variant of angiomatoid fibrous histiocytoma or intracranial myxoid mesenchymal tumor. This tumor has a female predominance, mostly occur in second and third decades, predominantly extraaxial or intraventricular, but can arise throughout the neuroaxis. Imaging shows contrast enhancing, well circumscribed, solid and cystic growth pattern with pronounced peritumoral edema. Microscopy shows wide morphological spectrum with stellate, spindle, epithelial, rhabdoid or round cells in a mucin-rich or collagenous stroma with low mitotic count. Tumor cells are positive for EMA, vimentin, SMA, desmin and CD99. Molecular study shows fusion of FET family gene, usually EWSR1, with a CREP family transcription factor. This tumor has a propensity for local recurrences and occasional dissemination or metastasis. Resection is the mainstay of management. The patient referred to RCC for further management. As the patient underwent gross total resection of the tumor and no residual lesion in post-op MRI, she is kept in close follow-up and currently on anti-epileptics. These are my references. Thank you.
The case is now open for discussion.
Any queries? If there are no queries, I'll. What is Dr.
Pravanya.
What is FET? FET? Pravanya?
Dr. Pravanya, are you there?
RNA binding protein, ma'am.
Yeah, what is FET? What is the full form? Those are the three things: FUS, EWS, and TAF. FET. Okay. And what are the other fusions you said?
FET and CREP, ma'am.
Yeah. And why is the term myxoid avoided?
Myxoid.
All the examples may not show that myxoid matrix. Okay, so EWSR1 CREP fusion, that will show a lot of myxoid material. The other fusions are ATF1, EWSR with ATF1, which will have more of an epithelioid morphology. And this does not have any particular morphology to talk about. And then these tumors may have meningioma-like whorls. Many examples have meningioma-like whorls. So that's why meningioma comes in the differential diagnosis. And this is a paper on the histological correlation between the histology and the molecular. So we find that 100% of these tumors with EWSR1 CREP fusion have a stellate or spindle cell morphology. And most of the tumors having this fusion, EWS ATF1, will have an epithelioid or rhabdoid morphology. So that is one point to note. And these are the diagnostic criteria for intracranial myxoid tumor. These are tumors of uncertain differentiation. That is a heading given. And there are a few more tumors also. And this is a provisional entity in that. So now we'll move on to the next case.
Case from Sri Gokulam Medical College, case number 13, to be presented by Dr. Aparna Mohanlal.
Good morning to all. I'm Dr. Aparna Mohanlal, Junior Resident SGMC, presenting case number 13. Clinical history revealed 51-year-old male, known case of type 2 diabetes mellitus and systemic hypertension, presented with back pain of 3-month duration and progressive spastic paraparesis without bladder and bowel dysfunction of 1 month, no history of fever, malaise, weight loss or any trauma, no relevant family history. Neurological examination showed hypertonia of bilateral lower limbs with decreased sensation below D8 on both sides. Knee jerk and ankle jerk were brisk bilaterally. Bilateral plantar responses were extensor and no lymphadenopathy. MRI dorsal spine showed an extradural lesion at the level of D6-D7 compressing the spinal cord. Post-contrast study showing contrast-enhancing lesion at D6-D7 level with extension to the paravertebral spaces along the right neural foramina. There are photomicrographs of scanner view, low power, high power. Case is now open for discussion.
Okay. Dr. Aparna, these were the responses. Majority, a vast majority for an Rosay-Dorfman disease, a few for an inflammatory pseudotumor, plasmacytoma with amyloid, and somebody also raised whether it could be an Erdheim-Chester disease. So we'll move on to the second part of your presentation.
Additional details: a CT-guided biopsy from the lesion was done, but it was inconclusive. Patient underwent D6-D7 laminectomy and excision of the extradural lesion. These are photomicrograph of the excision biopsy. This is scanner view which shows cellular infiltrate with focal collection of lymphoid cells. Low power, the cells identified predominantly as histiocytes arranged in sheets with lymphocytes and plasma cells. On high power, these histiocytes showed forme to dense eosinophilic cytoplasm with evidence of emperipolysis. This image is highlighting the histiocytes with emperipolysis and the other cells are lymphocytes and plasma cells. Morphologically, these features suggested the possibility of Rosay-Dorfman disease, and IHC was done to confirm the nature of the histiocytes. Histiocytes showed positivity for S100 and was negative for CD1A, confirming the diagnosis of Rosay-Dorfman disease. Therefore, the final diagnosis given was Rosay-Dorfman disease spine. Coming to discussion, lymph node is the most common site of involvement. Cervical lymph nodes are the most common. Skin is the most common extranodal site. Other extranodal sites include bone, upper respiratory tract, CNS, orbit, retroperitoneum, etc. CNS involvement is seen in less than 5% of cases, of which isolated spinal involvement is a very rare entity. Literature has shown only 60 cases of isolated spinal Rosset-Dorfman disease till 2016, hence we are presenting this case. These are similar cases of spinal Rosset-Dorfman disease which has been reported. Rosset-Dorfman disease in the spine usually affects in the mid-30s and the 40s with a male predominance, and the main presenting symptoms are either due to myelopathy, radiculopathy or pain over the involved spine. Constitutional symptoms like fever, malaise and weight loss are usually absent in isolated spine lesions. Here, in our case, the patient presented with back pain and progressive spastic paraparesis without any other constitutional symptoms. It can be either slowly progressing symptoms or acute onset weakness. On microscopy, the histiocytes characteristically display emperipolysis. Although emperipolysis is a key feature, it may not be present in the late stage, and differential diagnosis of such histiocytic lesions without emperipolysis include Langerhans cell histiocytosis and Erdin-Chester disease. They can be differentiated from Rosset-Dorfman by clinical history, morphology of the histiocytes and IHC. Rosset-Dorfman disease does not have any established treatment guideline. It is a self-limiting disease for those without any CNS involvement. In case of CNS involvement, it usually needs treatment, and surgery is the mainstay of treatment as it serves both diagnostic and treatment purposes. Local recurrence is possible following surgical resection. Follow-up, our patient improved symptomatically in the post-operative period. At 1 month follow-up, the patient is able to walk without any support and is having good bowel and bladder control. This is a case of extranodal Rosset-Dorfman involving the spine. We also had a similar extranodal Rosset-Dorfman of the soft tissue in the thigh. These are my references related to the case.
The case is now open for discussion.
Thank you.
Any questions? Dr. Aparna, do you mean to say that you need to see emperipolysis to categorize something as a RDD? Okay. So, just one query, how do you differentiate this particular entity from an Erdin-Chester? Since somebody has raised that suspicion, would you like to throw some light on there?
Okay, ma'am. Ma'am, am I audible?
Yeah, you are.
Ma'am, emperipolysis is a characteristic feature, but it is not specific for Rosset-Dorfman disease.
Yes.
And in case, in order to differentiate from Erdin-Chester disease, in case of Erdin-Chester, there will be clinical history is significant. Clinical history of multi-organ involvement will be present, and comparing the clinical history with the radiologist and predominantly Chester predominantly involves the bone, and therefore otosclerotic features will be present in radiology. And along with the biopsy, the histiocytes are predominantly foamy histiocytes. Lipoid changes will be present in the histiocytes, and foamy presence of these foamy histiocytes is predominant fibrosis, and lymphoplasmacytic infiltrate will be also sparse in case of Erdin-Chester. Then in IHC, when we see S100 will show only total positivity, and they will be CD18 negative and positive for CD68 and CD163. Thank you, ma'am.
Very good. Okay, that was a rare case. Of the spine. That's a very important point to be noted. The location is a very rare location for an RDD to happen. Thank you so much. Yeah.
I think now we'll move on to the next case.
The last one.
The last one of the discussion cases at 15 from Amala.
Aparna, before that, immediately after the slide seminar, we have the business meeting. So I request nobody to leave that Zoom platform.
Yes, sir.
So Dr. Chandni Thomas.
Good morning. I'm Dr. Chandni Thomas, Junior Resident,
Amla Institute of Medical Sciences, presenting case number 15. This was the clinical history provided. 73-year-old male with history of fall and 1 episode of seizure, followed by loss of consciousness. He was also complaining of headache, and on examination he had wound of his right forehead. On further investigations, MRI and CT brain were suggestive of meningioma, and he underwent craniotomy and excision of the mass under general anesthesia. HND section under scanner view, low power, high power. Case is now open for discussion.
So these are the differential diagnoses that we got. Most of them have said IgG4 related disease, and there was a differential of lymphoplasmacytic meningioma also. Now we'll go to the second part of the case.
Additional clinical details. This was a case of 78-year-old male with history of seizures, loss of consciousness and headache, non-case of diabetes mellitus and bronchial asthma, and on physical examination he had a wound on his right forehead. MRI taken was reported as right temporal meningioma, and CT also showed features suggestive of meningioma. His preoperative evaluations showed elevated ESR. He underwent right frontotemporoparietal craniotomy. The mass was excised and then sent for histopathological examination. Microscopically, sections showed tissue with dense fibrosis, predominantly in storiform pattern. So we can see areas with storiform fibrosis. Also noted were blood vessels of varying caliber with obliterated lumen by perivascular concentric fibrosis. Tissue also showed dense infiltration by eosinophils in sheets and in areas by sheets of plasma cells and lymphocytes. So with the clinical history and histomorphology, the differentials considered were IgG4 related disease, lymphoplasmacyte-rich meningioma, and eosinophilic angiocentric fibrosis. We went ahead with IHC. CD138 was positive, confirming the significant plasma cell infiltrate, and YMT was also showing diffuse positivity. EMA and PR were negative, which ruled out the clinical suspicion of meningioma, and IgG4 was positive in scattered cells. Postoperatively, he had his serum IgG4 levels checked, and it was within the normal range. So with the clinical history, histological features, and immunohistochemical analysis, we concluded the case as IgG4 related disease. And the patient was subsequently started on prednisolone and mycophenolate mofetil as a steroid-sparing immunosuppressive therapy. He responded well and is currently better with no focal neurological deficits. Coming to discussion, IgG4 related disease is an immune-mediated fibro-inflammatory disease of unknown cause characterized by infiltration of one or more target organs by IgG4 positive plasma cells and lymphocytes. Most commonly affected organ is pancreas, and it do affect other organs as well, including bile ducts, gallbladder, lymph nodes, retroperitoneum, kidneys, breast, prostate, lungs, brain, and skin. Clinical presentation can vary with respect to the organ involved, and common presentations are mass lesion or organ enlargement. And the inflammatory infiltration and fibrosis can result in tumor-like effects and can cause obstruction or compression complications. The three key points of diagnostic criteria include diffuse or localized swelling or masses in one or more organs, elevated serum IgG4 levels, dense lymphoplasmacytic infiltration, storiform fibrosis, and or obliterative phlebitis, along with IgG4 positive plasma cells, which can either be more than 10 to 50 per hyperfield or IgG4-IgG ratio more than 40%. And it is to be noted that presence of elevated IgG4 in the serum is a weak diagnostic feature, as up to 50% of patients with IgG4 related disease do have normal levels, and many other diseases are also associated too. So the diagnostic workup combines clinical, serological, imaging, and pathological information relevant to the tissue or the organ involved. About neurological IgG4 related disease. Involvement of the central nervous system is relatively uncommon, but increasingly recognized with hypophysitis and hypertrophic patchy meningitis as frequent manifestations. And just like the systemic disease, it do usually have a benign clinical course with excellent response to glucocorticoids, which is best in the early course of the disease, that is before when the extensive fibrosis develops. So, accurate and rapid diagnosis is important to prevent unnecessary surgical intervention and organ failure. Take-home messages are: IgG4-related disease is a multi-organ chronic inflammatory process. Its intracranial involvement is better recognized recently only. And early recognition and therapy are important in order to prevent serious irreversible tissue damage. And since its clinical features are non-specific, it's crucial to consider it as a differential diagnosis in cases having these histopathological morphology. Thank you.
Any questions?
What about your patient other involvement of other systems, and did you see any obliterative phlebitis in any other sections?
Dr. Chandra?
Ma'am, yes ma'am, am I audible?
Yeah.
And ma'am, histopathology sections that we studied from this case, from the excised tumor, we could see features of obliterative phlebitis, which we highlighted using Mason's trichome. And as the patient is concerned, there are no other features or symptoms related to any other vasculitis.
Thank you.
Any other feature to suggest disease activity? Any other morphological feature?
Pardon, ma'am?
Any other morphological feature to tell you about the disease activity? You said IgG4 serum level is not specific. Anything else you can
ma'am, the plasma concentration, plasma cells per hyperfield, the number of the plasma cells per hyperfield can be taken into account.
You can check for the plasma blast counts, the bigger cells.
Yes,
they're useful biomarkers for diagnosing this entity. And also assess the response to treatment. That is the important point. And what will you see on the CSF study?
In CSF studies, it has been reported about the intrathecal IgG4 and also the about oligoclonal glands patterns of production of IgG synthesis has also been reported.
What you see. Yes. Any more questions? Otherwise, we'll go on to the spotters. Actually, we received many more cases which we could not include because of the 15 number case restriction. So we have included many in the spotters, and we'll just rush through them. And I think we can make it available on the site for everyone to see later.
Yes. So the spotter one was from GMC Kozhikode. This was toxoplasmosis. And 2 was from Lisi Hospital in a 27-year-old. And this was a papillary lesion with a papillary architecture on on IHC, 7 positive, 20 negative, showed nuclear positivity for TTF1, confirming metastasis from lung. And the 3rd case from Pushpagiri was a known case of carcinoma breast, tumor cells in myxoid background, the same taking up ER, nuclear positivity, PR was negative. And the HER2 was showing membranous positivity, confirming carcinoma metastasis from the breast. And case 4 was a spotter from KMCT Calicut. This was a dural-based lesion with HPC-like vascular pattern. EMA was negative, CD34 was positive, showing a nuclear expression for STAT6, confirming solitary fibrous tumor. And this is actually not a spotter case, contributed by Sri Chitra in a 30-year-old, a cerebral lesion showing areas which resemble an embryonal tumor with small blue cells. And there were also areas with fibrillary background, areas of geographic necrosis. There were areas showing gematocytes. GFAP was in the blue cell, it was showing only like entrapped neurons. And it was only 2 negative. This is very, very important feature. This was negative in the blue cell area. ATRX was lost. P53 was showing, P53 was positive. And this was showing a positivity, nuclear positivity for the H3G34R mutation. So this is a diffuse hemispheric glioma, H3G34 mutant. And spotter 6 from GMC Trivandrum is a gliosarcoma with two different components. The spindle cell component, the reticulin highlighting the spindle cell component and negative in the glial component, and GFAP highlighting the glial and negative in the spindle cell component, Vimentin highlighting both. So this is a gliosarcoma. Spotter 7 is from Amrita Institute. Again, a high-grade glial neoplasm. On the right side, you can see the geographic pattern of necrosis, but the cells are all like plumper, more epithelial looking, with some on the right side showing intranuclear inclusion, and on IHC it was GFAP positive, and the tumor cells showed a positivity for BRAF 600E mutation. So this is an epithelial glioblastoma. Spotter 8 from Believers Church, a myxopapillary ependymoma. This is the GFAP. And spotter 9 is from Amrita Institute, Kochi, a case of primary, an elderly with multiple intracranial lesions. You can actually see the vasocentric pattern of round cells, very aggressive looking tumor. This is the reticulin pattern. Actually, the tumor cells are held onto the vasculature by thin, good reticulin network. And this was positive for LCA, 20 was positive, 3 was negative, and Ki67 was 70 to 80%. And spotter 9 is a choroid plexus papilloma with nice papillary pattern, but no alarming or high-grade features. But the point to be noted was this was from a 58-year-old lady. Age was actually not of the usual age. This was 7 positive, 20 negative. GFAP was negative. EMA showed a luminal positivity. We sent the case to NIMHANS to get the very characteristic marker, that is KIR 7.1, which was positive, confirming choroid plexus papilloma.
Now we have taken out the choroid plexus papillomas from the group of glial tumors. It's a separate entity now in the classification.
Yes, and spotter 11 is from MOLC Kolangeri, from 24-year-old. It's actually a mixed germ cell with majority showing a seminomatous component. There were glandular areas like this, and this is showing like a mixture of seminomatous and glandular and myxoidy areas. And this was the seminomatous area showed c-KIT positivity. Some of the glandular areas showed AFP positivity. The serum and the CSF serum markers were very elevated, and some of the glandular structures also showed up cytokeratin. So this is a mixed germ cell tumor with predominant seminoma, a yolk sac, and a teratoma as well. Spotter 12 is from, again, MOLC Kolangeri, a very classical case of a adamantinomatous craniopharyngioma. Point to be noted here is that craniopharyngioma, earlier it was classified into two different entities, that is adamantinomatous and the papillary. Now these are two different types because of the molecular change that is showing. The two different types showing different molecular alteration. And spotter number 13 is from 5-year-old child, Ames Kochi, posterior cranial fossa, blue tumor, but intervened with nodules, paler nodules. Reticulin showing the paler nodules are reticulin poor, whereas more cellular areas are reticulin rich. Synaptophysin highlighting the paler areas, the neuronal differentiation, Ki67 more in the intervening area, less in the nodular area, confirming a desmoplastic/nodular medulloblastoma. Case 14 was from, and this is for the PGs. Kindly go back to this article. This is a wonderful article to know entire of medulloblastoma. And spotter number 14 was from TDMC Alappuzha, a granulomatous lesion in the brain with brown colored fungal hyphae, confirming a pheohyphomycosis. And spotter 15 was from GMC Kottayam, which was from a 40-year-old, and a lesion in the spine, which was intramedullary lesion, which is showing cells in the nest, and they are GFAP negative, synaptophysin and chromogranin positive, and there were larger cells in between. Larger cells, I think it's not visible in this power, so that qualifies for a gangliocytic paraganglioma. And I'll take a few minutes for the last spotter because this was in actually it is definitely not a spotter, but
wanted to include
this was contributed from Aster, and since we couldn't take more than one case from a single center, and invariably every center called it a meningioma. As you can see here, this is
there was a history of meningioma.
so probably, and looking at some cells, that would have made them call it as a rhabdoid meningioma. This is the tumor brain interface, and you can nicely see that the tumors are like centered around some vessels here. This is the tumor brain interface. It is a tumor which is pushing, not an infiltrating. Very important point to be noted. The second image again highlighting the perivascular arrangement. Sorry, stuck here. Again, highlighting those perivascular arrangement, and another point to be noted in the upper image is that these vessels show very characteristic hyalinization. Again, a point to be noted. And this is probably the reason why everybody thought there is a history of meningioma, probably, and there were rhabdoid cells, rhabdoid cells. And this is the IHC markers. Vimentin is positive, GFAP focally, S100 positive. EMA showing characteristic perinuclear dot-like positivity. I am rushing because of the want of time. Kindly pardon me for that. IDH was negative, ATRX was retained, and there is a retaining of INI1, and Ki67 is very, very less. So this is and this case was sent to NIMHANS from Aster, and they have called with after doing some more markers. They have called it as an astroblastoma. This is a very classical case of astroblastoma. I'm going back to the morphology. Any tumor which shows a perivascular, very sclerotic vessels. You might see the sclerosis in the stroma as well. And this has to be an astroblastoma is now classified in the WHO, taking into consideration the molecular alteration. And we call astroblastoma as astroblastoma MN1 altered. So
rhabdoid cells are described in many cases of astroblastoma.
And
so
also
maybe the original tumor was also
astroblastoma. And one more point was astroblastomas are usually in adolescent or young adults. Again, this is a 65-year-old lady, but we have some case reports in the literature which says about the rhabdoid morphology and a long-term outcome even after 12 years of follow-up. So a big thank you to all of you from me and Aparna for choosing us to be the moderators and for the overwhelming response and the support that we received across the journey. And I cannot just mention about Shankar sir. The first response that we received was from GMC Kottayam. 15 days ahead of the date, we received the response on February 10th, and that too with a few lines of appreciation. And Shankar sir, it meant a lot to us because you are our teacher who have taken a major role in our formative years. So it was indeed it came as a booster to us. Thank you each one of us for appreciating our effort and also encouraging us to come up with this slide seminar.
And the postgraduates too, there was a little bit of problems here and there, but they too sent us the PowerPoints on time and did some corrections as we had said. So, and Bindu did most of the work. I was just supporting her all the time. So it was nice moderating a session again after 9 years.
But that support was really great, Aparna.
So, Aparna and Bindu, it was a wonderful session, and the time management was very good. Okay, so I think you finished.
Got the mic very late, around 10:30, I think.
Yeah. No, but I think I cannot forget Rajesh here, the man behind the show. His support was actually the main thing behind this show.
For so many days now, we are behind.
Thank you, Rajesh, for the wholehearted support.
Luckily, there was not much technical problem. Maybe
yes,
in the
sir.
initial part there was some jumping of flags was there, but otherwise it was smooth. Okay, so congratulations to both of you.